I hope that you have the basics and then you have come to the rapid revision course. Definitely we are not going to go in the detail of everything, but whatever is necessary for NEET PG, FMG as well as INICT, the core concepts we are going to see. Right? And after every system, we are going to look at the homeostatic point so that it's kind of a summary of all the system that we have discussed throughout. And please remember that the faculties are going to talk with each other and the things should not be repeated from one subject to another subject. So we are going to take care of that also. Please have some basics and then come to the rapid revision. That's the only, you can say, terms and condition for the rapid revision. So with that disclaimer, let's start the rapid revision of physiology. The first system is going to be general physiology. We all know that the homeostasis, that is the maintenance of constancy of internal environment, is very, very important to have the maximum efficiency in the body, and whatever body is going to have the give the functions to us, right? So they are going to be regulated by different regulatory systems. In that, the homeostasis, first of all, understand the homeostasis terminology was given by the Walter B. Cannon. Walter B. Cannon. Now, I told you what is homeostasis. It is the maintenance of internal environment or maintenance of constancy of internal environment. For that internal environment, we are going to give one fancy terminology. Not we per se. There was someone which is known as Claude Bernard. Claude Bernard, he was the scientist who gave the terminology for internal environment, and that is called as milieu interior. Please remember how to remember these terminologies. The short form of this, that is milieu interior, is MI, right? Whenever the person is going to have MI, he is going to go to the clouds if we do not treat that person within time, right? So please remember MI and cloud, right? And please remember the gods are also there in the cloud. Whenever you want to talk to the god, you look up like this in the clouds. So please remember, he's the god of physiology, or I can say he's the father of physiology. All right. And this homeostasis or internal environment is going to be maintained by different regulatory mechanisms. Please remember that there are going to be two different types of regulatory system. What are those two different types? First is going to be feedback system and second is going to be feed forward system. Feedback is further divided into two subtypes, that is positive feedback and negative feedback. Positive feedback and negative feedback. All right. Thankfully, feed forward you don't have to remember what is positive, what is negative. Remember that the feedback, that means if you have to come back from a certain point, you have to go to that point first, right? And if you want to go forward, you can go from wherever you are. So please remember, why I'm saying so is that feedback system, that means you have to have the stimulus first, then only you're going to get the response. But in the feed forward system, the correction will start to happen even before there is any change into the variable. What I mean by that? Let's see. First of all, remember that feedback system, and which is the most common regulatory system, is the negative feedback system, right? Everything goes in the negativity. So see over here, homeostasis. So the mother is asking that why you do have less marks. That means negative feedback from the teacher, and the boy is saying that she's teaching homeostasis. Why I have given you this meme? Please remember that the most common regulatory mechanism is going to be negative feedback. Most common means there are going to be thousands and thousands of examples of this negative feedback, and we are going to do the smart study. We are not going to waste the time only doing hard work, right? So what we are going to do? We are going to do the smart study. That means we are going to remember the examples of feed forward system and positive feedback. Remaining all are going to be the examples of negative feedback system. Right? So see over here, ye dil mange more. That means we want more and more and more and more and more things. That is nothing but your positive feedback system. And if something is counteracting, that means if you give the stimulus and you get the response which is inversely proportional to the stimulus, that is going to be your negative feedback system. For example, let's see, if the BP is increased, what will happen? there are receptors known as baroreceptors will be activated, and that will decrease BP. Right? Same is going to happen if there is increased BP is there, that means hypertension is there, chemoreceptors are going to get activated and they will decrease the BP. Let's say glucose is increased, the insulin is going to help us out to decrease the blood glucose. That means it is going to take the glucose from the blood and put it into the tissues. Right? So it is going to be a negative feedback system. Something was increasing, we have decreased it. So it is in the inverse correlation with the stimulus. The response is inverse correlation with the stimulus, that is going to be negative feedback. So let's look at the positive feedback system and feed forward system. Rest all examples are going to be the negative feedback system. Now, to remember the positive feedback system, I have the mnemonic that is H2 clamp. H2 means there are going to be two H. First H is Head's paradoxical reflex. Next H is going to be Hodgkin cycle, clotting cascade, LH surge, activation of digestive enzyme, milk letdown reflex, which is also known as milk ejection reflex, and the parturition reflex, which is also known as Ferguson's reflex. Right? What do you mean by parturition? Parturition literally means delivery, right? So during the mother's delivery, that means when the mother is delivering the baby, at that time this parturition reflex is going to get activated, and whenever the mother is in the lactation period, at that time the milk is going to come out. Whenever the baby is going to suckle on the mother's breast, the milk is going to come out of her lobules, right, of the breast. So the question that they are going to ask is, which hormone is responsible for both of them? Oxytocin is going to be responsible for both of them, milk ejection or the parturition. How this is going to take place? Let's see. So first thing first is that, let's say this is a parturition reflex. Let's say this is the uterus of the mother and this was the fetus. Right? Now the fetus wants to come outside. What will happen? First of all, uterine opening, that is your cervix, mother cervix. So the cervical dilatation will occur as soon as the baby start to descend during the delivery. Right? So as soon as the cervical dilatation is going to take place, what will happen? This will go and stimulate the hypothalamus. This hypothalamus is going to stimulate the posterior pituitary, and from the posterior pituitary, I'm going to have the release of oxytocin. This oxytocin is going to act on the receptors of the uterus, and please remember the oxytocin sensitivity is very, very high during the delivery. How? Because the receptors on the uterus, they are going to increase. The mother's uterus, they are going to increase. As soon as the oxytocin is going to sit onto the receptor, what will happen? The uterine contraction will start. Now understand, as soon as the uterine contraction will start, the baby will be pushed even more with the force. What will happen because of that? That baby's descent is going to be start happening, and that because of that descent, even more cervical dilatation will occur. More cervical dilatation means more will be the hypothalamic stimulation, more will be the posterior pituitary stimulation, more will be release of oxytocin. This cycle continues on and on and on unless and until the baby and the placenta both are out of the uterus. So please remember, this is like a positive feedback system. So ye dil mange more. Please remember that. Same is going to happen that whenever the baby is going to suckle onto the mother's breast, the mother's breast are going to have the tactile receptors. Those tactile receptors send the signals to the hypothalamus. The hypothalamus again send the signal to the posterior pituitary. The oxytocin will be released. That oxytocin in the lactating mother is going to act on the myoepithelial cell of breast. Myo means muscle. So please remember, the muscles are going to contract, and in between those muscles, the mother's breast are going to have the lobules. When the muscles are going to contract, these lobules will be compressed, and whatever milk was stored into those lobules, that is going to come out in the baby's mouth. That is known as milk ejection reflex. Please remember, when they are going to ask about who is going to eject the milk, which hormone is responsible, your answer will be oxytocin. Who is going to produce the milk? If they ask about production of the milk, milk production के बारे में पूछा है, so please remember if they ask about specifically about the production of the milk, then it is going to be prolactin. Production, prolactin. But if they ask about ejection of the milk, we usually write the ejection like this, but I'll write like this so that it will be easier to remember. Please remember that is going to be oxytocin. Ejection of the milk, oxytocin. Production of the milk, that is going to be prolactin. Alright. Head's paradoxical reflex. What is Head's paradoxical reflex? In a newborn baby, the first cry of the newborn, what is going to happen is that when the baby is going to be born, at that time he is going to cry. And when he is going to cry, the inflation of the alveoli will be stimulated. That means the inflation of the alveoli will further stimulate the further opening or further inflation of the alveoli. Right? So that is going to be your Head's paradoxical reflex. Usually in adults, what happens is inflation is going to inhibit the further inflation so that the alveoli will not burst. But since in the fetal life, the alveoli are collapsed, I want to open up at a certain level. And that's why whenever the baby is born, at that time, this Head's paradoxical reflex is going to get activated. What about Hodgkin cycle? This Hodgkin cycle is seen in the action potential. What is it? The opening of fused sodium channel opening during the depolarization will stimulate the more and more sodium channel opening, more opening of or more you can say sodium channels will be opened up, right? So, please remember, more and more sodium channels will be opened up because of this Hodgkin cycle, and that's why the depolarization will be able to reach to the spike. Alright, then coming to the clotting cascade, factor number 12 or factor number 3, depending on intrinsic or extrinsic pathway that is going to get activated. They will activate many enzymes unless and until the fibrin thread is formed. LH surge, you all know, as soon as the ovulation is going to happen, before 32 to 36 hours before the ovulation, what will happen? The LH will stimulate further release of GnRH, that will increase further LH. That cycle goes on and on and on unless and until the LH peak happens, and then suddenly the LH is going to drop. So that is known as LH surge. That is also a positive feedback mechanism. Activation of digestive enzyme. One enzyme is going to get activated, that is from the trypsinogen we are going to activate enterokinase, which is going to break down this trypsinogen and it will convert it into trypsin. Right? And as soon as the trypsin is formed, it gets activated. That will go and activate many more enzymes. So this is also like a positive feedback mechanism. So please remember H2 clamp, that is Head's paradoxical reflex, Hodgkin cycle, clotting cascade, LH surge, activation of digestive enzyme, milk ejection reflex, and parturition reflex. Right? So that is about the positive feedback. Let's see the examples of feed-forward system. I told you that in the feed-forward system, what will happen? Even before you have some change in your main variable, even before that, the corrections start to occur. How is that possible? Remember that whenever let's say the exam is coming. When do you prepare for the exam? When the exam is going on or even before the exam starts. Of course, you prepare even before the exam starts, and that's how the body also prepares for whatever stress is coming, right? And this is nothing but your anticipatory control. You anticipate that this is going to happen. For example, the teachers are going to anticipate that these are going to be the concepts which were asked in the last exam, so they can be repeated, and hence we are going to focus on those topics whenever we take the rapid revision or PYQs, right? All these topics, all right? So that means we anticipate what is going to happen. Right? So same is going to happen, that the correction occurs even before the variable has been changed, not after giving the stimulus. First example is temperature control. Now temperature control is little bit tricky. Why? Because remember, there are two types of temperature. First is your skin temperature. Skin temperature, if they ask, we call it as shell body temperature. As soon as the cold environment, let's say there is a cold environment means low temperature. that low temperature is going to decrease the skin temperature. As soon as the skin temperature start to decrease, what will happen? There are going to be something known as thermoreceptors which are present, which is going to sense the temperature in the skin. They are going to go and give the signals to the hypothalamus. As soon as the hypothalamus is going to get activated, when it is going to get activated? When the skin temperature falls. We are taking the example of low environmental temperature, right? So when the skin temperature is going to fall, that is going to give the signals to the hypothalamus. And as soon as the hypothalamus is active, what will happen? Definitely, as the hypothalamus is going to be active, that is going to activate some mechanisms such as shivering, vasoconstriction. Especially in the periphery, we do have shunt vessels in the skin, which will, if they constrict, what will happen? The heat loss will be prevented. Right? So we have to prevent the heat loss. So that is going to happen. And with the shivering, what will happen? Shivering means it is the involuntary muscle contraction. Whenever the muscle is going to contract, two things will happen. First thing is ATP or energy is going to get utilized. And second thing is the heat is going to get released. Right? And that is how the heat will be generated. And remember, there is another temperature which is known as core body temperature. Core body temperature means deep tissue temperature and the blood temperature. That is going to be maintained. So, the core body temperature didn't even fall. Even before the core body temperature falls, we started activating the shivering and vasoconstriction, all these heat producing mechanism or heat conserving mechanisms. Isn't it? So that means the correction started way before the core body temperature falls. So that means this is none other than feed forward mechanism. So please remember, if they ask about core body temperature, then this is going to be feed forward mechanism. If they ask about skin temperature, of course, whenever the shivering and vasoconstriction is going to take place, at that time, later on the skin temperature is going to increase. That means the skin temperature is negative feedback. Alright. So both the things are going to be there, feedback as well as feed forward. If they ask about shell temperature or skin body temperature or skin temperature, then it is going to be negative feedback. But specifically, if they ask about core body temperature, blood temperature, deep tissue temperature, then it is going to be feed forward. What about the next example? Increase in the heart rate just before the exercise. Let's say the exercise is exam, right? Even before you start giving the exam, your heart will be saying dug 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 dug, right? That means your heart rate will increase even before the exam start, you know? So even before one day, we are not able to comprehend what will happen tomorrow. So that means your body is anticipating that yes, that is going to be the stress which is going to occur. In this case, the stress is nothing but the exam. Alright, why you have the heart rate increased or tachycardia even before the exam starts? Because it knows that this is going to be a stressful situation, and at this time, my brain is going to require a lot more ATPs, oxygen and nutrients, right? To provide that high demand, I'm going to prepare my body even before the stress starts, right? So that is what is your feed forward mechanism. So over here, the exercise example is given. So let's talk about exercise. When you're about to start the exercise, your brain anticipates that yes, this person is about to start the exercise. And when he's going to start the exercise, the muscles are going to contract. And for the muscle contraction, I have to provide more blood, more oxygen there so as to have the maximum output out of that contraction. And hence, the feed forward mechanism is going to get activated. Cephalic phase of third example is cephalic phase of gastric acid secretion. Cephalic phase. Cephalic means brain. Alright. As soon as you smell something favorite, your favorite food, right? So smell, or you have a sight of it. That means you see some of your favorite food, or you even have a thought about it. You were thinking that after this class, I'm going to eat that thing, right? I have completed the RR, so I'm going to eat that particular thing which you love, right? So the thought of it, the sight of it, the smell of it can stimulate the gastric acid secretion. Your brain is only thinking about it. You haven't had the food yet. You are just thinking about the food. What will happen if I take the gastric acid secretion rate right now? Then definitely it will be seen to be increased. Why is it so? Because your brain thinks that you are about to eat that food. So it prepares your GIT beforehand. So please remember, this is also a feed forward mechanism. Now, I need to know that I have so many regulatory systems, but how much benefit they are doing to my body, right? So please remember, this is measured by, that is the efficiency of regulatory mechanism is measured by something known as gain. How to calculate a gain? There is a formula that is known as correction upon error, right? Let's take an example. So let's say the BP was, the mean blood pressure of a person or a dog was 100 mmHg. If he has the baroreceptor and we give a particular amount of stress, what will happen? Let's say even after giving a stress, the mean blood pressure rises to around 110 mmHg. But remember, if the baroreceptor, we cut the baroreceptor of that dog, what will happen? Let's say the BP, the mean blood pressure shoots to 140 mmHg. That means if the baroreceptor is not there, instead of 140 mmHg, the blood pressure only risen up to 110. That means the baroreceptor is doing the correction of 30 mmHg. So what is the correction over here? 140 minus 110. Why? Because if the baroreceptors were not there, the BP would have shoot to 140 mmHg, which is now only shooting. When the baroreceptors are present, that will only shoot up to 100. That means there is a correction of 30 mmHg and there is some error left. That means the BP didn't come back to 100 mmHg, right? There is some amount of error left. So this is the error which is left. Okay, so how much is the error that is left? 10 mmHg. Please remember that the correction that has happened, the BP was increasing, but baroreceptor decreased the BP. That means it was going in the opposite direction. The correction always happens in the opposite direction to that of the stimulus. So we are going to apply the negative sign in front of it. So that is going to be -3. The -3 is the gain in this condition. Why? And what does that mean? The baroreceptors has 3 times, you can say, if the baroreceptor is not there, the BP will rise 3 times more. So please remember, the gain over here is -3. That means 3 times my baroreceptors are reducing the increment in the blood pressure, and it is always and always is going to be in the negativity. Why? Because the correction always happens in the opposite direction to that of the stimulus. Alright, so please remember, correction upon error. Alright, so let's move on to the cell membrane. Cell membrane, we all know that the most accepted model is the Singer-Nicolson model, that is nothing but the fluid mosaic model. Now, if I ask you, what do you mean by fluid over here and what do you mean by mosaic over here? Then this fluid represents the lipid in the cell membrane, and mosaic means it's a form of Greek art which literally means randomly present. Who are present randomly in the cell membrane? They are nothing but your proteins. So proteins are present randomly. So please remember, lipids and protein, they are the main parts, and that's why we accepted this model. That is nothing but the fluid mosaic model, right? And who are most abundantly present? If I ask you the question, which of the following is most abundantly present, or which of the component is most abundantly present in the cell membrane, then your answer should be proteins. So look over here, we are going to write CHO for the carbohydrate. So if I ask you to count the alphabets, protein has more alphabet, right? So please remember, the proteins are going to be the most abundant component of the cell membrane. How much it is? 50 to 55%. The lipid is going to give the contribution of 40 to 45%, and carbohydrates less than or equal to 5%. If I ask you that which is the most common lipid, then your answer should be phospholipid. Again, I'm stressing upon this. If they ask what is the most common or most abundant component of cell membrane, your answer will be protein. If I ask you most common lipid, then your answer will be phospholipid. So please remember that, okay, phospholipid. And if I ask you whether do you have cholesterol or not in the cell membrane, of course you do have cholesterol in the cell membrane. See over here, this is the diagram of the cell membrane, which is the bilayer lipid or phospholipid layer is going to be present, and the proteins are going to be randomly present. Two types of proteins are there. First, that the proteins can cross both the membranes, that is outer membrane of the cell and the inner membrane of the cell. So these are known as the integral protein, which can act as a transporter or channels or the receptor, right? And we do have proteins, either they are attached only to the outer membrane or they are attached only to the inner membrane. Then they will be called as peripheral protein. Even if they are only attached to the inner membrane, then also we are going to call it as the peripheral protein. Only if they are crossing through and throughout the cell membrane, then only we are going to call them as integral or transmembrane protein. And see over here, we do have the cholesterol in the cell membrane. Very important. When we are going to talk about the function, we'll talk that it gives the flexibility and fluidity to your cell membrane. Alright, so please remember the most common lipid is going to be phospholipid, and this is also known as amphipathic lipid. What do you mean by amphi? Amphi means both. For example, let's take the animals, amphibian animals, the animals which can live on the land and in the water, both the ways, right? So they are known as amphibian. So amphi over here means they have both the properties, water solubility also and lipid solubility. How? Because these phospholipids are going to have two parts. See over here, it is going to have the head part and it is going to have the tail part, right? The yellow ones are the tail parts. The H for head and H for H2O. So please remember H for head, H for H2O. So they are water loving. And in the tail you have L. So please remember they are lipid loving. Okay. So lipid loving means lipid and water cannot go hand in hand. So please remember they are hydrophobic. What do you mean by phobia? Phobia means excessive fear, isn't it? So the tail part is feared of, or it is having the excessive fear of water. So, and if I ask you which is the most important property out of these two, so see over here, when I'm going to attach or make the bilayer lipid membrane, then the tail part is going to cover maximum surface area. So please remember the most important property of the cell membrane, that is the solubility, is given by the tail. What do you think? Which substances it is going to allow? Of course, the lipid soluble substances. The lipid soluble substances will be allowed to cross the membrane. Lipid soluble substances, they can cross the membrane because I'll just write CM, that is cell membrane, because the tail part is going to come in between and that is going to give the major property to the cell membrane. Alright. And if I ask you which lipid is going to be absent in the cell membrane, is it going to be cholesterol? No. Cholesterol is still present. So which lipid is going to be absent? The lipid that is absent in cell membrane, that is none other than Teen tigada kaam bigada. We usually say in the Hindi, that is one of the, you can say the statement, that means three. If three people are there, the work will not happen. Alright. So triglycerides are the saturated forms. So triglyceride, that is TG, is not going to be present in any of the cell membrane. Alright. So please remember TG is going to be absent in the cell membrane. Now, this is about the components, alright, and percentage, how much percentage it is going to be present. But if I take the mass of the protein and mass of the lipid is more in number, but it is less dense. It is lighter as compared to the proteins, which are going to be heavier in the mass, right? So if I take a mass, the ratio is going to be 1:1. 1:1 ratio is going to be there, alright? But if I say that, are there any exceptions? Of course, if medicine would have been that easier, everybody would have done that, right? But not everyone is medico. So there are some exceptions and those exceptions can be asked. So if I ask if the ratio is higher, that means there are more proteins. Which things are going to have more protein in their cell membrane? Two things you have to remember, that is inner mitochondrial membrane. Mitochondria, you know that it is going to have two membranes. inner and outer. The inner mitochondrial membrane is going to have more proteins as compared to the lipids, and the sarcoplasmic reticulum, I'm just writing SR over here. Sarcoplasmic reticulum also has more of the protein as compared to the lipid. If you want to remember, the ratio is 3:2. Alright. Then if I ask that in which of the following the ratio will be lower, is there any exception? Yes, lower means they're going to have more lipids. Right? Protein to lipid ratio is lower. That means the denominator is going to be much more. So please remember that is going to be your myelin sheet. Myelin sheet has almost 80%, 75 to 80% of the lipid. That means lipid is much higher. So these are the exceptions. Please remember them. Alright. And the meme that is shown over here, see that this is the water molecule, or you can remember that as a water soluble molecule. The cell membrane is asking that you want to pass through. That is just not fine with me. You need appointment. That means water soluble substances require a specific type of protein. They cannot just cross the membrane like that. Alright. Why? Because the phospholipid, especially the tail part, they give the solubility property. Who gives that? Phospholipids. Which lipids? Phospholipids. Alright. And there is one more property that is known as structural integrity, which is given by all the lipids. Then they are going to ask you flexibility and fluidity. What I mean by that? Flexibility, fluidity means you do have flexible cell membrane. It is not going to rupture by minute trauma. Alright. So that is given by the cholesterol. Alright. Structural integrity means whenever the exocytosis and endocytosis is going to take place, still the membrane will be intact. Still the boundaries of the cell membrane is going to be intact. Then why we require protein? Integral protein and peripheral protein. We just now discussed that if they are attached to one, you can say part, inner or outer part of the cell membrane, they are called as the peripheral protein. If they are crossing the membrane through and through, they are known as transmembrane or integral proteins. Alright. I require water soluble substances also inside the cell membrane, or let's say the water soluble substances also requires to cross the membrane. They cannot cross via the phospholipid, so I have to apply specific doors, and those doors are made up of these proteins. For example, channels, pumps, transporters, symporters, and the receptors, right? The carrier proteins, they are going to be there for the water soluble substances to let them cross or allow them to cross the membrane. And what is the antigen? Antigen is nothing but the identity card of the cell. We do have phagocytes, right, which is nothing but the army of my body, especially the, you can say neutrophil and the monocyte, macrophages. What they do, that they are going to fight against the bacteria. But for that, they have to identify which is my own cell, my own body's cell, and which is the foreign antigen. How they are going to identify? With these antigen. Please remember, we do have specifically two types of antigen, MHC1 and MHC2, that is major histocompatibility complex. Major histocompatibility complex. On the all nucleotide cells, my own body cells, I'm going to have these MHC1 type of cell, right? And MHC2 are majorly present in the foreign antigen. And if the foreign antigen, let's say a terrorist has a gun or any modern, you can say weapons, my armies should also contain that weapons so that they are able to fight with them, right? So please remember the antigen presenting cell. The APCs, that is the antigen presenting cells, they do have such as Langerhans cells, the B lymphocytes, they also they have the MHC2 and except the antigen presenting cell, none other cell is going to have this MHC2, right? They are going to have the MHC1. Right. So let's move on with that. This is the all what we have discussed till now. These were the role of lipid and the proteins. Now let's come on to the support system. If anything is giving you the support, we call it as skeleton. And cell, inside the cell, I need to keep everything intact on its own place. For that, I require a system, and that I'm going to call it as cytoskeleton because it is giving support to my cell. Alright, three major things are going to be there. You just have to remember the names of them. First is going to be microfilament, and whichever is starting with the M and M, they are going to be dynamic. That means they are going to move. Alright, and whichever is not starting with them, of course, it is going to be static. It will not move. So first thing first, microfilament. So look over here. If I talk about the actin, actin is actually a globular molecule, right? If a single actin molecule, if I take, that is a globular in structure, round in structure. So that's why it is known as globular actin or G-actin. But they polymerize and form a filament, and that's why they are known as filamentous actin. So this is the microfilament. Why? Because those actin molecules, many actin molecules, they come together and form a filament. That's why it is known as filamentous actin. So if they ask about microfilament, you have to give the name actin, F-actin or G-actin. Now what is the role of it? Remember, we just now talk about the phagocytosis. Let's continue with that. The phagocytosis are usually present in the blood vessel. Whenever anything harmful comes in my body, they have to go out of the blood vessel. How they are going to go out? They are going to squeeze through the endothelial cells. That means whatever endothelial cells are going to be there, they are going to create once a little space, right? From that little space, if my neutrophils and monocytes wants to go out, they have to shrink, they have to squeeze, and then they have to go outside. And you must have listened or heard about the actin and myosin in the muscle contraction. So yes, this actin is going to help me out in the muscle contraction also. And the process that I told you that they're going to go out of the vessel via squeezing, that is nothing but your diapedesis. So yes, that is going to help us out in the diapedesis and muscle contraction. With that, we all know that this is going to help us out in the mechanical support. That's why we are studying it in the cytoskeletal system, isn't it? Then coming on to the intermediate filament. Intermediate filament, again, let's say you are posted in surgery department and you got one tumor, right? Now what we are going to do? We need to know which type of cells are there in this tumorous, you can say, growth. So you cannot just see and tell what type of cells they are. So what you are going to take? You are going to take the biopsy and send to the pathologist. Pathologist is going to add the stain, look at the intermediate filament, what is the cell marker, right? And according to that, they're going to identify. So 4 names you have to remember, that is cytokeratin, desmin vimentin, and GFAP protein. What is cytokeratin? We talk a lot about keratin and there are so many ads about keratin. We all know that the keratin is found in the epithelial cell. Epithelial cells, right? About the desmin, vimentin and GFAP, just remember the look at the third alphabet, that is desmin. You do have S. So please remember they are found in the skeletal muscle. Don't get confused between the smooth muscle and skeletal muscle. I told you just focus on the third word, not the fourth alphabet, right? Third alphabet, all right? About the vimentin, M is coming. So these are present in the mesenchymal cell. They are present in the mesenchymal cells. Right? And GFAP, that is glial fibrillary acidic protein. Glial fibrillary acidic protein, they are found in the astrocyte. They are found in the astrocyte. So please remember all these names. Let's move on to the microtubule. You can see over here, there is a tube-like structure and it can polymerize or depolymerize. All right. Now, if I have to transport one thing from one side of the cell to the another side, how can I transport it? With these tubules, right? First thing, let's say you want to go from one city to another city and you have to book the train for that. Then for the train, we require a track first, right? And the cargoes, that is train ka dabba. All right. So the track is made up of this tubulin proteins. All right. So microtubules are going to form that tracks, okay, which are going to help us out in the intracellular transport. So please remember there are 2 types of proteins, that is alpha and beta tubulin. Thankfully, it doesn't have any fancy name, right? Microtubules are made up of tubulin. Tubules made up of tubulin, right? Now, these tubulin proteins can help us out in the cell division also, but remember they're not the alpha and gamma ones. They alpha and beta ones, they are the gamma tubulin. They are specialized tubulin. Gamma tubulin is going to help us out in the cell division. All right, just remember the names. All right, with that, let's move on forward. Intercellular junction. Remember the name, intercellular. That means now we have come out of the cell now. We're talking about two cells and their junction. So see over here, if I zoom it out, let's say this is cell number 1 and this is cell number 2, cell number 3. What you can see over here, these cells can communicate with each other. Right. So see over here, if I zoom it out, one junction, this will look something like this. This is the cell membrane of one cell and this is the cell membrane of another cell. What you can see that they are coming closer at one side and they have a specific proteins by which they have present or they have produced a gap between them, or they have made a pore-like structure so that a substance can pass through from the ICF of one cell to the ICF of another cell. What is ICF? Intracellular fluid, right? What is the benefit? The electrolyte or that substance doesn't have to cross the plasma membrane, go into the ECF, again find another channel and go into the ICF of another cell. That means I'm going to save a lot of time. So very quick transport is going to happen with this shortcut, and this shortcut is known as gap junction because that is going to produce a gap between two cell membranes. All right. So please remember these gap junctions are connecting two cells. So the protein which is going to be helping us out, that is known as connexin. Why? Because it is connecting two cells with the help of gap. All right. And how many such subunits are going to be there? So count with me. It is going to be 6 such subunits which are going to connect together and form the connexon. So please remember, this is the closed position. When this gap is going to be opening up, there will be a pore which is going to be generated so that the electrolytes or substances can transport very quickly from one cell to another cell's ICF without entering into the ECF. All right. So gap junction, they are going to do the quick transport. And let's take the example of where you are going to see this. You're going to see that in the cardiomyocyte or single unit smooth muscles. That means urinary bladder, gallbladder, even the vessels, blood vessels, right? And let's say uterus. In all those smooth muscles, you're going to find the gap junction. What is the benefit of that? Let's take the example of cardiomyocyte. Cardio means heart, myo means muscle. Ventricles. Let's take the example of ventricle. One ventricle, left ventricle or right ventricle. They're made up of thousands and thousands of muscle fiber. But when you have to do the ejection or you have to do the systole, all of these muscle fibers has to contract at the same time. So how they're going to contract at the same time? Thanks to this gap junction, what the gap junction is going to do is, as soon as electrolyte changes happen in the one muscle, through the gap junction, they will be transported towards the another cell and from the another cell to another third or fourth cell. All right. So with that, all of these muscle fiber, they're going to act as a one single unit. They will not act as a different muscle fiber, but they will act as one ventricle, one single unit. And that one single unit is known as a fancy terminology for this one single unit, that is syncytium. All the cells act as a one single unit, syncytium. Please remember that, syncytium. So please remember connexin, connexon. 6 such subunits are going to come together of the connexin and form the connexon. Connexin, connexon, quick transport via the gap, that is gap junction. All right. With that, let's move on to the another cell junction. Let's say you ate any street food. Now, you don't know what type of water that person has used, right? You do not want anything, let's say toxins, bacteria, viruses to go enter in your CSF. Why? Because this is a VIP organ, right? So you have to have the barrier in between. So who are going to act as a barricades or barrier? That is nothing but your tight junction. They will not allow the paracellular junction, transport, right? So let's say these are the two cells, right? If the cell is going to have some transport, if the transport is occurring through and throughout of the cell, one channel is there, another channel is there, right? Through and throughout of the cell, then if something is going across the cell, we call it as trans. Trans means across. So transcellular transport, right? But if the cell is not having per se a transport, but the substance is crossing the membrane, or let's say it is crossing the sides of the cell via the transport that is from the periphery of two cells. That is known as paracellular transport. From the periphery of the cell, if the substance is getting transported, that is known as paracellular transport. Now, if I do not want this paracellular transport to occur, what I need to do? I need to put the barricades over here, right? So, which are the proteins which are going to put the barricades? Now, let's remember that with the mnemonic. If I put a barricades, let's say some president or someone is going on from the road, and since this is a VIP person, so they have put the barricades. So, because of that barricades, what will happen to the traffic? Either the roads are going to get closed or partially occluded, or there will be a traffic jam. Now, this is going to be your mnemonic. Roads are going to get closed. So, remember clouden, right? Closure. So, clouden is going to be there, or they are going to get occluded, that is occludin, or traffic jam, that is JAM. Jam is junctional adhesional molecules. Junctional adhesional molecules, they are going to be producing this tight junction, where these tight junctions are present, where we do not want the paracellular transport. For example, the blood-brain barrier, that is BBB, that is blood-brain barrier. Even the blood-testis barrier also contain these tight junction. You do have that in the GIT also, and in the nephron. Please remember, the nephrons, they are going to, filter out all the waste particles. We are going to secrete waste particle. I do not want that waste particle to come back in my blood. So I need to have the tight junction at that level. All right. So in the blood-brain barrier, blood-testis barrier, nephron, GIT, you do have these tight junction. Just remember the name. And they have asked about the Vibrio cholera. Their toxin is also going to affect, especially the occludin. All right. So zona occludens 1, that is the specific protein on which the Vibrio cholera toxin is going to act upon, right? And the person will land up into the stool, diarrhea, that is rice gruel stool, right? Rice gruel stool, if they ask, because of disruption of occludin, and hence the water cannot stay inside the blood vessel. It is going to cross the membrane, come into the GIT, person will land up into diarrhea. Please remember that. Now, the third one, adherent junction. Adherence means to stick, right? These junctions, they are going to sticking the cells together. Via sticking of the cell, what we are going to get? We are going to get the strength to the tissue, right? So, that is their work. And they have asked the question on the cadherin. Cadherin itself, if you hide the C, you're going to have the name itself there. Adherin, cadherin, right? So, adherent junction is made up of cadherin. With that, you can remember the name, that is actin and catenin. They anchor the cell together, or they stick the cell together and give the strength. So, please remember the proteins, actin, catenin and cadherin. At least remember the cadherin, all right? Let's move on to the next thing, that is body water. Now, you guys are going to remember one rule for me here, that is 60-40-20 rule. Now, what is the 60-40-20 rule? 60-40-20 rule is, if I give you the body weight, out of that 60% will be total body water. Out of that 40% will be ICF, that is intracellular fluid inside the cell, and 20% will be extracellular fluid, that is outside of the cell. Since I have most of the activities going on inside the cell, cell is my factory, so that's why I require more water inside the cell. All right. So if I give you any body weight, let's take 100% over here for our convenience right now. So out of that, how much will be the total body water? Total body water is going to be 60%, isn't it? And that 60% I'm going to divide into 2. That is ICF and ECF. What is ICF? Intracellular fluid. How much it will be? It will be 40% of the body weight. Please remember that. Okay. And ECF, that is extracellular fluid, that will be 20%. Extracellular fluid will be 20%. This extracellular fluid is further divided into 2 parts. What are the 2 parts? First is the interstitial fluid. interstitial fluid. From now onwards, we are going to write it as IF, right? And then is going to be the plasma. How much is the interstitial fluid of the body weight? Out of this 20%, see the name, bigger the name, bigger will be the contribution. Remember that ways. All right. So 15% of body weight. Since we are taking the body weight as 100%, for the weight I'm writing just WT. All right. That is the short form. And 5% of body weight. So whatever I have written in the pink color, that is in consideration of the body weight. If I take the body weight as 100%, then the plasma will be only 5%. So now if I ask you, if I take the ECF as 100%, then how much will be the interstitial fluid of the ECF? You have to make the 4 parts, and out of that 3 parts will be given to the interstitial fluid. Alright, so that means 75% of the ECF will be your interstitial fluid and 25% of ECF will be your plasma, right? So that is how you have to remember. Now one more question that they have asked, that there is something known as, one more thing that is known as transcellular fluid. What is transcellular fluid? It is the fluid which is present in the cavities, right? What are the cavities that we have in the bodies? Such as pleural cavity, pericardial cavity. So I'm just writing pericardium, peritoneal cavity, pelvic cavity, synovial fluid, again synovial cavity, right? Then even the CSF. All these are present in the cavities. But please remember, if I calculate all of that transcellular fluid, that won't even come as 1 liter. Usually it is less than 1 liter or equal to 1 liter. So we won't bother about it. Just they have asked till now that transcellular fluid is a part of, it is a part of ECF. Please remember that whichever fluid is present in the cavities, that is going to be coming under this transcellular fluid. Alright. If I ask you the last question, that the total body water, if I take total body water as 100%, then what will be the ICF and ECF? Please remember, 2/3 of the total body water, that I'll write it as TBW. 2/3 of total body water will be your ICF and 1/3 of TBW will be ECF. Alright. So no matter what they are going to ask, you have to remember it. And 60-40-20 rule, please remember that rule. If I ask you that there is a 70 kg man is given and we have to calculate, let's say ICF. I know that the ICF is going to be 40%. So what I'm going to do, I'm going to multiply it by 40. I know that it is going to, divided by 100 because I'm calculating the percentage. So I'm just going to do 7 into 4. So that will be equal to 28 liters. It is going to be very easy. Just multiply it by 2 or 4 depending on whether they have asked about ECF or ICF. Please remember that. Alright. So that is going to be one of the example that I wanted to give about. Please remember the 60-40-20 rule. Let's move on. If I have to estimate how much is the body fluid that is going to be present, what we are going to do? We are not going to get the ideal situation all the time. Right? That means only ICF will be 40% or ECF will be 20%. Might be the patient is suffering from diarrhea or vomiting from last 2 days. So the concentration is going to change. So if I have to measure the volume, what I'm going to do? I'm going to use a method which is known as dye dilution method. Dye dilution method. The name itself is telling you what is this method all about. What I'm going to do? I'm going to take a syringe and I'm going to give a dye IV intravenously. I'm going to introduce a dye. When I'm going to introduce a dye, and I'm going to wait so that that dye will distribute all over throughout the body. As soon as it started to distribute, what I'm going to do, I know that after this much time it will be distributing in a particular compartment. I'm going to take a small sample out of the plasma and I'm going to check that in this much amount of blood I have found this much dye, and I know what amount of dye I have given. Right? So according to that, I can calculate overall volume. Alright, so this is known as dye dilution method. Dye dilution method. What is the formula to calculate the dye dilution method? In the 12th standard or in the 11th standard, we used to +1 + 2 mein, we used to use the formula that is amount is equal to concentration into volume. The same formula we are using over here, just we are considering the volume. So just take the C over there or take the V over there, and or let's say I'm going to take the C over there. So what will happen? If I take the C over there, I'll get the volume. So volume is equal to A by C. So please remember A, B, C. By means upon, right? So A by C, that is A upon C is going to be the formula. But the exception is, again the medicine comes, right? Medicine is not that easy. The body is not an ideal situation. In the body, some dye will be excreted or metabolized. So I have to take that into consideration. So whatever dye has been excreted out, that means it is not getting distributed in the compartment. So I will not calculate that. I'm going to subtract that percentage from the amount. So the formula will be A minus E upon C. A minus E upon C will be the formula. What is A? A is the amount of dye, which we already know because we are giving that after measurement, right? E is the excreted part or the metabolized dye. That amount we are going to subtract already, and C is the concentration of the dye. Alright, so please remember A, B, C and just do the change, that is minus E. Alright, because the body is not the ideal condition. Now, we have to remember the dyes also, right? So let's say that I have put a dye into the plasma via a syringe and a needle, right? Now, this is a dye, let's say a type of dye which can cross the plasma membrane also, go in the interstitium, and which can cross the cell membrane also. That means it is going to go in all the compartments and can give me the total body water, isn't it? But if I say, let's say this is the ICF that is inside the cell, right? And this total is the ECF. This inside, if something is present inside the blood vessel, we are going to call it as plasma. And if it is not in the blood vessel, not in the cell, we are going to call it as in between, that is interstitial fluid. Now, if I have that particular dye which we talked about earlier, then it is going to give me the total body water. Fine. Why? Because it is able to cross all the membranes, plasma membrane as well as cell membrane. But if I have another dye which is only able to cross plasma membrane, but it is not able to cross the cell membrane, then it is not entering inside the cell, so it will not be able to give me the cell wala, you can say volume, right? So it will not be able to give me ICF, it will only give me ECF volume. Okay. Now, if I take the third dye, and if I told you that the third dye, whichever I have taken, it is only staying inside the plasma, it is neither crossing the plasma membrane, and of course, if it is not crossing the plasma membrane, there is no question of crossing the cell membrane, isn't it? Now, this type of dye is going to only and only give me the plasma volume of the fluid that is present inside the blood vessel. Alright, if I have to measure the IF, that is interstitial fluid, and ICF, can I measure via giving the dye? No. Why? Because whatever dye we are giving it in the plasma. That means we are giving it in the vein, we are giving it in the blood vessel. Nothing can go out without going into the plasma. So I cannot measure the interstitial fluid or intracellular fluid directly. For that, I require two different dyes. Why? That is known as indirect method. What I'm going to do, if I have to measure ICF, what I'm going to do is, I'm going to first of all measure all of this volume, that is total body water, and when I'm going to measure the total body water, out of that I'm going to subtract the ECF. The remaining will be ICF. So that is known as indirect method. In the direct method, we require one dye. In indirect method, we are going to require two different dyes, right? So what is ICF? How you are going to measure it? Total body water minus ECF, right? And how you are going to measure interstitial fluid? Again, the same method. You're going to measure the ECF first. See over here, ECF first, and then we are going to measure the plasma. Whatever remaining is left, that is known as interstitial fluid, isn't it? So ECF minus interstitial fluid. All right. For that, now I need to know what are the dyes which are going to measure total body water, ECF, and plasma. So let's see the dyes. If I ask you, give me the dihydrogen oxide, will you able to give me? Yes, because it's a water, right? And water is everywhere. So please remember, total body water. When I talk about total body water, water, H2O, D2O, T2O. We are going to use the twins of the H2O, that is T2O and D2O. What is T2O and D2O? T2O is tritium oxide. What is D2O? D2O is deuterium oxide. Tritium oxide, deuterium oxide, and third component, that is aminopyrin, which is also known as antipyrin. One and the same thing, right? So please remember, for the water H2O, you're going to use D2O, T2O, aminopyrin or antipyrin. What about ECF? For the ECF, we are going to have the mnemonic that you have to remember, that is Simon. What is Simon? S for sucrose, I for inulin, which is most accurate. Ma is mannitol. Inulin is most accurate. Please remember that. N is little bit tricky. N is sodium, right? But we do have sodium already in the body. I have to differentiate whatever sodium I have given to the person. So please remember, that is nothing but sodium iothalamate or sodium thiosulfate. Iothalamate or thiosulfate, these are the radio-labeled sodium molecules. Alright, Simon. Via the Simon, we are going to use the dye, which is nothing but measuring the ECF. Now let's come on to the plasma. See over here, in the plasma, we do have word asma, right? Asma in Hindi means sky, right? And usually the sky is blue. So we are going to use the dye which is also blue. And this blue dye was given by the scientist Ivan. So we are going to call it as Ivan's blue dye. And please remember, there is a very big molecule which cannot cross the plasma membrane, that is nothing but the albumin. We are going to label that with the radio-labeled substances, and that is why I am going to write it as radio-labeled albumin. RL means radio-labeled albumin, right? So either with the Ivan's blue dye or with the radio-labeled albumin, I am going to measure the plasma volume. All right. Let's move on to the Darrow-Yannette diagram. That is going to give us the shift of body water according to its osmolarity. So please remember over here, this diagram is known as Darrow-Yannette diagram. They have asked the name, right? Once they have given a diagram and just they ask what this diagram is known as. This is known as Darrow-Yannette diagram. Now, three osmolarities are going to be, we are going to learn about isotonic, hypertonic, hypotonic. And each of them is going to have two scenarios. Either loss is going to be there or gain of the fluid is going to be there. Now, two rules you have to follow in this. Whatever change is going to occur, the first change is always going to occur in the ECF compartment. That you have to remember. That is the rule number 1. And second rule is, both of the compartment, that is ICF as well as ECF, is going to maintain the osmotic equilibrium all the time. They're going to maintain the osmotic equilibrium all the time. So please remember, two rules you have to follow, and rule means they will be applicable in all the scenarios. All right. Let's see whether they are applicable, really applicable or not. Right. Isotonic. Iso means same. Tonic means osmolarity as compared to the plasma. All right. So if I have isotonic loss, when this is possible? Diarrhea, vomiting, right? Mild to moderate condition, right? So in that, I'm going to have the isotonic loss. So see over here, there will be two compartments. On the x-axis, volume will be given, and on the y-axis, osmolarity will be given. Volume. Now, let's say this is the condition. Now, let's say this is the condition which is a normal condition. If I say the person is losing isotonic fluid, I told you the first part of the rule is, that always the change is going to happen in the ECF first. So the person is going to lose the isotonic water from the ECF. So what will happen to the ECF volume? The ECF compartment volume is going to decrease. So see over here, which is shown. So ECF compartment has lost the water. So if I draw the diagram like this, so suppose this was the normal ECF and ICF compartmental volume. What will happen? The ICF volume will not change, and since it is isotonic fluid loss, so the tonicity or osmolarity which is given on the y-axis, that is also not going to change, right? So please remember, only and only the loss of ECF volume will be given, all right? Exactly opposite is going to happen if some person is, let's say, drinking the distilled water which is not having any minerals, all right? So let's talk about the gain. Exact opposite scenario is going to happen if I, let's say, introduce or infuse the normal saline which is going to be isotonic. So there will be gain of that fluid. So now what will happen, that if someone introduced a normal saline that is isotonic, so osmolarity will not change. And what is the first rule that we learn? That the change is going to happen in the ECF first. So what will happen to the ECF volume? Since we are having gain of fluid, so the graph is going to shift. That is, the volume compartmental graph of the ECF is going to shift towards the rightward. All right. So exact opposite scenario is going to be there. So if I draw the diagram like this, so this was the normal condition. What will happen? Nothing will change in the ICF, neither the volume nor the osmolarity. Only the ECF is going to have increment in volume. All right. So please remember these examples. All right. Let's move on to the hypotonic condition now. Hypotonic condition means whatever loss or gain is happening in that fluid, particularly, we do have lesser solutes and more solvent. That's why the osmolarity is lesser as compared to the plasma. Let's say hypotonic loss is there, such as condition is going to be diabetes insipidus. Diabetes insipidus, in that what happens is the ADH is not acting upon cell, or ADH is not getting released. So what will happen? I'm not able to absorb more fluid from the collecting duct via the ADH, right? Now what will happen? More and more water will be lost. Now, if the water is lost, what is going to happen? The first thing I know, that the first change is going to occur in the ECF. So, of course, it is a loss. That means the person is going to lose the fluid. So, what will happen to the volume of ECF? Volume of ECF is going to decrease. But please remember that this was the hypotonic fluid. That means I'm not losing the electrolytes. I'm just losing the water. What will happen to the osmolarity of ECF? Of course, we are just losing the solvent, not the solute. So, of course, the osmolarity is going to increase, right? But I cannot have unequal osmolarity between the ICF and ECF. Why? Because as soon as the one compartment is going to change its osmolarity, the water is going to move via the osmosis. So now what will happen? That the tonicity or the osmolarity of the ECF fluid has been increased, and hence what will happen? That the fluid from the ICF is going to shift into the ECF. So see over here, the fluid is going to shift from the ICF into the ECF. Since the fluid from the ICF is shifted into the ECF, so the volume of the ICF is also going to reduce, right? And the osmolarity is also going to increase because the fluid has moved. Only fluid has moved, not the solutes. Only solvent has moved into the ECF. So again, the osmotic equilibrium will be maintained. That means the x-axis, that is the osmolarity axis, is going to be constant, right? That means on the volume I'm having on the x-axis, right? So volume compartment will be compressed, or that is going to reduce in both ECF and ICF, and the osmolarity is going to increase. All right. So y axis is going to change as well as x axis. So see over here, if I say that this was my normal scenario, how the later on scenario is going to look like? This is going to look something like this. All right, both the compartment lost the fluid, and both the compartments have more osmolarity now after this condition. Exact opposite scenario is going to take place if the person is having SIADH. That means syndrome of inappropriate ADH secretion. For our convenience, we are going to remember it as increased ADH secretion. If the ADH is acting more and more onto the collecting duct, more and more water will be reabsorb back from the urine into my blood. Now what will happen? I am putting a lot of fluid in my blood. So blood will be hypotonic, right? And plus it is a gain of fluid. So of course, the fluid compartment, the volume is going to increase. And first change always occurs in the ECF. But eventually what is going to happen, because I'm putting a lot of fluid into the ECF, only fluid, not the salts, not the solutes. So the osmolarity, my plasma and the ECF to get diluted. That's why the osmolarity is going to decrease. But I cannot have unequal osmolarity. Later on, what is going to happen? First of all, the ICF osmolarity was more as compared to the ECF because ECF got diluted. And because of that, the volume is going to shift into the ICF. So what will happen to the ICF volume? It is also going to increase. So if I draw the diagram of ICF and ECF, and hypotonic gain, suppose this was the normal scenario, how it is going to look like afterwards? It is going to look something like this, that first of all there will be gain of the fluid in the ECF and loss of osmolarity. That means osmolarity is going to decrease, and this is going to look something like this. All right, so both the compartments will be having more you can say volume, but it is going to have lesser osmolarity. All right, the osmolarity will decrease in both the compartments, volume will increase. All right. And distilled water, if someone is drinking only the distilled water which is not containing any mineral, then also the same condition will arise. Then the third condition is about the hypertonic gain and loss. Let's say loss. First of all, let's say if hypertonic loss is there, such as in condition of hypoaldosteronism, what will happen? Hypertonic loss, that means I'm losing the solutes more than the solvent. So what will happen? Since I'm losing more solutes, so of course the tonicity or osmolarity will reduce, right? So when the osmolarity is going to reduce and it is a loss, some fluid is going to get lost. So what will happen to the volume of the ECF? The volume of the ECF is going to reduce. But with that, what is happening? That the ECF is also losing the salt, and because of that, what is going to happen? That the osmolarity of ECF is going to decrease. At that time, the ICF osmolarity was more. So what is going to happen? The fluid is going to shift even from the ECF into the ICF. So if the fluid is going to shift from the ECF towards the ICF, what will happen to the volume compartment of the ICF? The ICF volume is going to increase, and the osmolarity, since the ICF also got diluted because of the water entry from the ECF into the ICF, and that's why what is going to happen? The osmolarity is going to decrease. So please remember, the osmolarity is going to decrease in both the compartments. The ECF compartment is going to have a lesser volume because most of the volume gone into the ICF, and the ICF volume is going to increase. So the graph is going to shift towards the left hand side. The graph is going to be shifting towards the left hand side, left and lower side. That means downwards. So left and low is going to happen in the hypertonic loss. So LLL, remember that, okay? That is true in case of hypertonic loss. So the graph is going to shift towards the right hand side, and let's say this is the, let's take the same color. If I draw the diagram of it, how it will look like? It will look something like this. The graph is going to shift towards the left hand side and lower side. All right. Exact opposite is going to happen in the gain scenario, such as if you given more solutes as compared to the solvent. So that is going to be the scenario. Let's say you have given on lots and lots of solutes. So what will happen? If you give lots of solutes, so of course the osmolarity of ECF is going to increase. First of all, the osmolarity of ECF has been increased. Because of that, what will happen is the fluid from the ICF is going to shift. The fluid from the ICF is going to shift towards the ECF. If the fluid is shifting from the ICF towards ECF, what will happen? Fluid is losing, so osmolarity will come towards the equilibrium, right? But it will be losing some volume, right? And since it is losing the volume into the ECF, so ECF volume is going to increase. So the graph is going to shift towards the right hand side and upwards. All right, as it is shown in the diagram. So please remember, the osmolarity is going to increase and the volume of ECF is going to increase. On the other hand, ICF volume is going to decrease. All right. Please remember that. Next, the transport across the cell membrane. Transport across the cell membrane has two types. First is the active, second is the passive. We all know that active requires the energy, right? And when it requires energy, when we are going against the gradient, है ना? Like studying, right? Studying when all other people are enjoying is difficult, right? It's an active process. You require a lot of concentration and a lot of ATPs. Right? But if you are going along with the concentration gradient, like forgetting doesn't require any energy, right? After 2 to 3 months, we'll forget everything up if you do not revise. So that doesn't require any energy. Why? Because it is going along the gradient, So please remember, active is going against the gradient of the concentration gradient, right? And it requires the ATP. On the other hand, passive is going to go along with the concentration gradient and it doesn't require any ATP. Let's talk about the active first. The active transport is going to have three different types. That is, first is the primary active, second is the secondary active, and third is the vesicular transport. Vesicular transport, we'll talk about it later. For now, just remember that the vesicular transport is of three types. If something is coming inside the cell, that is known as endocytosis. Something is going out, that is known as exocytosis. And something is crossing the cell through and throughout, that is known as transcytosis. Endocytosis, exocytosis, and transcytosis. Alright. So let's talk about primary and secondary. Primary means it is going to use the energy. Of course, energy will be used in the active. So energy will be used directly in the primary active and indirectly in the secondary active. What I mean by that, let's take an example. Let's say you are going to meet your partner or you're going for the exam, right? And of course, your private vehicle is not working, cab is not coming on time. So what you decided? You have to go there. So you decided to take the public transport. If you decided to take the public transport, now what will happen is that, let's say the public transport is fully crowded. Still, you're going to do dishum, make some space and go inside. That means you have utilized your energy and reached to the destination. That means for your transportation, you have utilized the energy of your own, right? So that is like a direct, you can say, utilization of energy. Now, let's say when you're going somewhere, you have a small kid with you. Alright, so 5 years or 6 year kid. Same scenario, a crowded bus or metro or public transport came in front of you. Now what you will do? You have to make the space for that little kid also and for yourself also. So you are going to do dishum for yourself and dishum for that little kid. Now, both of you will get into that transport, public transport, and reach to the destination. Who is smart amongst you? Of course, that smart little kid, right? Why? Because that kid used your energy to reach to the destination. That means the secondary active transport is like that smart little kid, right? It is going to be dependent upon this secondary active transport is going to be dependent upon the primary active transport. Right? It is going to use the gradient which is generated by the primary active transport. What I mean by that, we'll understand with the example. Alright. For now, just remember that it uses the energy indirectly. The energy was used, but not of that small little kid, but your energy was used. Alright, to create that space. Now, how to remember the examples? P for primary, P for pumps. So please remember all the pumps are going to come under the primary active transport. For example, our Nokia pump, that is the sodium potassium ATPase pump, right? ATPase or pump, right? Then the calcium ATPase, hydrogen ATPase, one and the same thing. All of that are going to utilize their own energy to have the transport, but that is not in case of the indirectly using energy or secondary transport. Examples of secondary transport, first of all, remember they are of two types. Symport, that means if something is crossing the cell into same direction, that is known as symport. Same direction, which is also known as co-transport. And if something is going in the opposite direction, one is coming inside, one is going outside, that is known as counter transport or antiport. counter transport or antipode. What is the example of sympode and antipode? Let's take the example of SGLT, that is sodium glucose linked transporter. Antipode is sodium calcium exchanger. This is the standard short form nowadays. Sodium calcium exchanger. Let's see the example of SGLT and let's understand it. See over here, first of all, that this is the basolateral membrane on which I have this pump, that is sodium potassium pump. Focus on the sodium. What this pump is doing to the sodium? It is utilizing the energy and throwing the sodium out of the cell. If I'm throwing the sodium out of the cell, what will happen eventually to the sodium levels inside the cell? They are going to decrease inside the cell. Now, this is the gradient which is generated. Inside the cell, I have lesser sodium and outside the cell, I'm having more sodium. So, it will be easier for the secondary active transport to transport the sodium along with the gradient. So, suppose this is the lumen of GIT, right? So, it will be transporting the sodium along the concentration gradient from high concentration of sodium to low concentration of sodium inside the cell. Alright, and while it was going, the glucose will tag along with it and that is also going to go inside. So please remember, the sodium and glucose, they are going to get transported in the same direction. But in that, they are not going to utilize the energy specifically. Overall transport mein the energy got used. Who is utilized the energy? Energy was used to create the gradient. If the gradient is not there, of course, the SGLT will also not work. So, in the overall process, the energy got used, but that was used to create the gradient and that was used by the primary pump, right? So, yes, they are coming under the active, but they are not going to utilize the energy directly. Rather, the energy will be used to create the gradient and they are dependent on that gradient which is generated by the primary pump. I hope you understood this. Alright, so please remember that. Let's move on to the next thing, that is the passive transport. Passive transport is of two types. First is the osmosis. We all know the osmosis from 5th, 6th standard, right? So we are not going to discuss that. The water will move from high concentration of water to low concentration of water, or from the low concentration of salt to the high concentration of salt. That is osmosis. We all know, we are not going to discuss because the question will not be coming on that also. Then coming to the second passive transport, that is the diffusion. Diffusion has three different types. It is simple diffusion, facilitated diffusion or non-ionic diffusion. What is simple diffusion? Simple means it doesn't require ATP. Of course, it is passive. It doesn't require any protein, carrier protein also. For example, all the lipid soluble substances, they are going to cross the membrane with the simple diffusion. For example, gases, all the gases such as oxygen, carbon dioxide, ammonia, all of them are going to cross the membrane without utilization of any of the transport. How to remember? Some people also pass gas very easily. Very disgusting example, but helping us to remember. So please remember, gases can be transported very easily without any transport protein. And then the second one is the lipid soluble hormones. What are the hormones which are lipid soluble? They are nothing but your oid wale hormones, that is thyroid and steroid. Thyroid and steroids, they are going to be transported without utilizing any of the carriers. And the third is the vitamins. The lipid soluble vitamins such as A, D, E and K, they also get transported with the simple diffusion. Next, coming on to the facilitated diffusion. Facilitated one, in that C is coming. So please remember, it requires a carrier protein. I'll show you the diagram also. For now, just remember, suppose that this is the cell membrane and I have the transporter over here. They are coming under the passive. That means they are not utilizing the ATPs. They are just using the carrier protein. Then how the carrier protein is going to help us out? Remember, let's take the example of GLUT. Suppose that this purple one is the GLUT. That is glucose transporter, and this is the glucose molecule. The pink one is the glucose molecule. As soon as the glucose molecule is going to sit on that GLUT is going to have configurational change. It is going to change its figure, right? And what it will make? it will flip inside the cell and release the glucose. As soon as the glucose is released, it will come back to its normal position, right? That means without using the ATP, it only requires a carrier protein, not the energy. Please remember that. And with the use of carrier protein, it is going to have the configurational change and it will give me the transport of that particular substance. Now understand, this is a GLUT, that means glucose transporter. So it is going to utilize the carrier protein which is specific for glucose, hence we call it as GLUT, right? That means no other substance can be transported via this GLUT transporter. Amino acid, bicarbonates, they won't be getting transported via this. Only the glucose will be transported. So that means they're very, very specific. They're very, very specific. And please remember, they have limited number of these carrier proteins on each of the cell. After a particular concentration, they are going to get saturated. That means they are going to follow the saturational kinetics. They're going to follow the saturational kinetics. See over here, how to differentiate between simple diffusion and facilitated diffusion. See in this graph. Whenever the graphical question is going to come, my bacha party is going to do two things. What are the two things? First, don't get scared. The answer is there in the graph, right? And the second, see the x and y axis. You'll get to the answer very, very quickly. Concentration of substance is given on the x-axis and diffusion, rate of diffusion is given on the y-axis. When I'm going to increase the concentration of substance, what will happen to the lipid soluble substances? The rate of diffusion is going to increase. Why? Because as you increase the concentration of substance, the gradient, that is concentration gradient, is also going to increase. Alright. What about the facilitated transport? Facilitated transport, since it is using a specific protein, it will be faster as compared to the simple diffusion first of all. But as you keep on increasing the concentration of substance, the saturation will occur of that carrier proteins and that graph will be plateaued out, right? The plateau will come at the Vmax, that is the maximum velocity of that transport. And please remember, if you have, even if you cannot remember anything, please remember, if you have a simple straight graph, linear correlation, that is going to be simple diffusion of the lipid soluble substances. If you have a curved graph like this, which is getting to a plateau, that is going to be facilitated. C is coming in the facilitated. Please remember that it is going to have the curved graph. Alright, please remember that. Alright. With that, let's move on to the last one, that is non-ionic diffusion. The name itself telling you non-ionic diffusion. That means in the ionic form, my substances cannot get transported. Why? Because they are polar substances, right? They cannot cross the cell membrane without any configuration or without any transporter. Now, I have to transport the ammonium ion. So, see over here, NH4+, that is ammonium ion. But I don't have any transporter for ammonium. So, what I need to do, especially in the nephrons, what I'm going to do is, I'm going to convert that ammonium into NH3+, which is a gas, which doesn't require any transporter, and H+ ion. For the H+, I do have transporter. So, the H+ is going to get transported via the sodium hydrogen exchanger, which is already there, right? And the NH3 is going to get transported via simple diffusion because it's a gas, right? And this NH3 and H+ ion, finally, they are going to come into the lumen. Again, they're going to combine together and again form the NH4. So, first of all, I converted that ionized form into non-ionic form, that is NH3 mainly. Alright, and that NH3 got transported with the diffusion. So, please remember, this is known as non-ionic diffusion. In the ionized form, the substance cannot get transported. So, I have to convert that into non-ionic form first and then it will be transported. Please remember that. Next, please solve this question. Substance and type of a transport across the cell membrane, they are given. We have to correct the correct combination. You can pause the video and you can give your answer on your own. I'm going to go forward. Oxygen, simple diffusion, that's true, it's a gas. It is going to go through the simple diffusion. Glucose, facilitated diffusion. Yes, it can be facilitated and it can be secondary active. Via GLUT, it is going to be a facilitated one. Via SGLT, that is the sodium glucose link transporter, it is going to be secondary active. Both are possible, so that is also true. Sodium, yes, it is going to have the channel that is voltage gated, can be voltage gated, can be ligand gated. Sodium, secondary active, yes, in the SGLT that is possible, or sodium calcium exchanger, that is also possible. Calcium, it is active transport, possible. Just now we talked about sodium calcium exchanger, which is secondary active, that is also possible. So please remember all of that, they are correct. So my answer is going to be option C. My answer is going to be option C over here. Let's move on to the next substance. 43-year-old came, female came. For the routine checkup, we found out she's overweight, right? Asymptomatic thi, but we wanted to ask her to decrease the carbohydrate intake. Carbohydrate, transport of glucose across the cell membrane. Glucose require transport protein, whether that is GLUT or SGLT, it requires a protein. Whenever you are going to use the protein, it is going to carry through the facilitated transport or secondary active. Both of them are going to have the saturation because they are using the transporters. Transporters are going to get saturated, so the graph will be curved, right? So please remember, answer over here is going to be option B. Next, the transport system, again the PYQ is shown across the cell membrane, A to B, it is going from A to B, right? And we have to identify this one, arrow is shown over here. So see over here, they are using, this one is using the carrier transporter. They are not using the energy. If the energy is used, they will write it as A or B. And we know that, see over here, the concentration is higher this side and it is going along the concentration gradient. So please remember that this is going to be the facilitated transporter. If they have shown ATP over here, then I would have marked active, but they have not mentioned anything about the ATP and they have not mentioned anything against the concentration gradient. So the better answer over here is going to be facilitated transport. All right. If I talk about this seems to be a channel. Why? Because it is open. It is not going to do any configurational change. It is just going to move the substances or electrolytes mainly. Channel is simple diffusion, and if it is not using any carrier protein, then also it is simple diffusion. So first two are simple diffusion. The next one, since they have not mentioned any ATP over there, I'm going to think that it is the facilitated diffusion. It is the best answer over here. See, if the gate is given, gate is usually present on the channel. Channels are simple diffusion. What about this? This is showing the configurational change. It is moving, right? So it is facilitated diffusion. So both are the passive transport. And what is it? In the vesicle format, that means vesicles are the round storage bodies. In the vesicle format, if something is coming inside the cell, that is known as endocytosis. If something is going out of the cell, that is known as exocytosis, right? So over here, it is going out. So it is the exocytosis, and over here it is coming in, that is endocytosis, right? And you can see from one area, if it is coming out, and from one side it is going coming in and then going out, then it is crossing the cell. So I'm going to call it as transcytosis. All of that is going to be active transport. Now, about the vesicular transport, please remember, once in the INICT, they have asked this question, that there is a structure which is looking as if it is having three-legged structure. That is, it is looking like a triskelion. What is that? That is the protein which is going to have the receptor-mediated endocytosis. Endocytosis has three types. The phagocytosis, pinocytosis, and the receptor-mediated endocytosis. Out of that, the receptor-mediated endocytosis requires a specific protein, that is nothing but the clathrin or caveolin. So please remember, the clathrin or caveolin, they are the proteins which are going to be used over here. And the structure which is shown over here, which is looking like as if it is having three legs, that is going to be your triskelion. And for the detachment, you can see over here, there is a spring-like structure which is used, and the protein is known as dynamin. It is not dynin, please remember, dynamin. I have specifically highlighted the M over here, right? So protein name you have to remember over here. That is all for the general physiology. Let's quickly go through the homeostatic point, that is the summary points. First, most common regulatory mechanism or regulation is going to be negative feedback, isn't it? Then coming on to the main lipid, it is going to be phospholipid, which is the lipid which is absent, that is going to be triglyceride. Barriers are made up of tight junctions, and the syncytium is made up of gap junction. Gap junctions are made up of connexin or connexon. Tight junctions are made up of occludin, claudin and jam protein. Body water rule. What is the body water rule? It is 60-40-20 rule. What are the dye used for the ECF? That is nothing but the Simon. Sucrose, inulin, mannitol, sodium, iothalamate or thiosulfate. Plasma, asthma, Evans blue dye or Evans blue dye or radio labeled albumin. I'm just writing RL albumin. Alright, active transport are of three types: primary active, secondary active and the vesicular transport. In the vesicular transport, I'm going to have endocytosis, exocytosis and transcytosis. In the primary, all the pumps are going to come. In the secondary, either it is going to be symport or antiport. And in the passive transport, remember it is going to be osmosis or the diffusion. Or it is diffusion, and diffusion is of three types. First is the simple diffusion, facilitated diffusion or the non-ionic diffusion. So that is all about the general physiology. So let's start with the nerve muscle physiology. First thing first, we all know that whatever cell membrane we are having, that is semi-permeable. That means it will allow the lipid soluble substances and it will not allow the water soluble substances. Now, understand all the ions are also water soluble, but the thing is, during the rest, some of the ion channels, they are open even during the rest. So what is going to happen if the channels are open? Those particular ions are able to come out or go inside the cell. So they are known as diffusible ions. Please remember that whichever ions are able to cross the membrane during the rest, so they are known as diffusible ion. The ions which are not able to cross the membrane, they will be called as non-diffusible ion. So that is very important. Diffusible ions, which are the diffusible ions? So please remember, it is none other than the potassium and chloride. Potassium and chloride, right? So potassium and the chloride, they are able to cross the membrane even during the rest. Alright, so potassium and chloride, they are able to cross the membrane during the rest. So they are known as diffusible ions, and the rest of them are known as non-diffusible ions. For example, sodium, calcium, bicarbonate, phosphates, proteins, all of them are called as the non-diffusible ions. Diffusible ions are also known as permeant ions, or non-diffusible ions are also known as non-permeant ions. Diffusible or permeant, one and the same thing. Non-diffusible, non-permeant, one and the same thing again, right? Now, there is some effect which is known as Gibbs-Jonan. Let's understand with a very nice analogy over here. You must have seen the tug of war. What happens in the tug of war is that one team will be pulling the rope on one side and the another team try to pull the rope on the other side. Same happens with our ions also. For example, let's take that this is the cell. And we just now talked that during the rest, the potassium channels are going to be open, and that's why the potassium will be able to go outside. Now, as the potassium is going outside, what will happen? Let's say the potassium concentration is more inside the cell, right? And it wants to go outside the cell. So if the potassium is going outside the cell, and if it is more, let's take arbitrary numbers, that is 110 over here. Now, till what point the potassium should move outside? Till it becomes equal both the side. That means both the side it should be 55 and 55 ions. In total, we have 110 ions. So 55 both the sides. So that is going to be called as equilibrium. But this is not the condition in which our body is going to be there. That means in our body, in vivo, this will not be the condition. Why I'm saying so? Because understand, there are going to be other ions which are there inside the cell, such as phosphates, proteins, and phosphates and proteins, they are negatively charged ions. So please remember that yes, the potassium will move outside because of its concentration gradient. But we do have other non-diffusible ions inside the cell also. So what they will do? They will follow the law of nature, or they will follow the law of physics. What is it? That opposite attracts. That means the opposite charges that we are going to have, they are going to attract each other. So phosphate and proteins, they are negatively charged ions. They will attract the positively charged ion, that is nothing but the potassium. So what will happen? Yes, the potassium will start going outside, but it will not go outside till it becomes 55. Let's take the number as 20. Right? So only let's say 20 molecule went outside. That means in total I'm having 30 molecules outside, and remaining inside is 80 molecules. There are going to be 80 molecules inside. Now what will happen? That since the positive molecules are going outside, now the negativity will be increased inside the cell, and that will attract more potassium ions, and that will not allow even more potassium ions to go outside. So that means there is a creation of electrical gradient. I'm writing it as delta E over here. So yes, the concentration gradient was outside, but now the electrical gradient has created inside the cell. So when this electrical and the concentration gradient is equal and opposite, the potassium movement or the flow of potassium towards outside will stop. So this is known as equilibrium potential of the cell or of that particular ion in the resting condition. Now please remember why this happened, why the potassium was not able to go outside till it becomes 55 both the side, because in vivo we do have the non-diffusible ions, and they are going to affect the distribution of diffusible ions such as potassium and chloride. So please understand, this is known as the Donan's effect or Gibbs-Donan equilibrium. Gibbs-Donan equilibrium. So what is it? The distribution of diffusible ions, that is going to be, diffusible means permeant ions, and that is going to be affected by the non-diffusible ions. So there will be some effect of the non-diffusible ions on the distribution of diffusible ion, jisko we can call it as the permeant ion also. So whether they ask about distribution, diffusible, non-diffusible, DDD, if that comes, please remember it is none other than the Donan's effect or Gibbs-Donan equilibrium. And because of this, what will happen? There will be generation of potential. What we are going to do over here is that we are going to put two electrodes, one electrode, microelectrode inside the cell, one electrode outside the cell, and we are going to connect it with the voltmeter. What will happen? We are going to measure the magnitude of potential difference for that particular ion. Till what point it is going to give me the equilibrium potential. And that is known as the Nernst equilibrium. Why? Because he was the scientist who discovered it. So please remember that is known as Nernst equilibrium. Before going to go towards that, just discuss, let's discuss what are the ions which are going to be more inside the cell, what are the ions which are going to be more outside the cell. If I talk about cations, T looks like positive. So please remember the positively charged ions, they are known as cations, and N for negative. So negatively charged ion, they are known as anions. Intracellular fluid mein, that means inside the cell, what are the cations which are going to be in the most abundant format? That is going to be the potassium. Potassium is the most abundant cation present in my cell. But if they specifically ask which is the divalent cation which is more inside the cell, potassium is monovalent. It is not divalent, right? So I cannot give the answer as potassium. Then my answer should be magnesium. Please remember, it is not the calcium. The calcium is going to be more outside the cell, not inside the cell. Alright, then if I talk about the anions, we just now talked about the phosphate and proteins. They are going to be more inside the cell, which are definitely the negatively charged ion. That's why we are writing in the anion column. Now, if I ask you about the extracellular fluid, please remember, as we developed in the seawater, we till now also we have the tendency that for the nourishment, I require more salty water outside of my cell, and salt means mainly the sodium and chloride. So please remember, sodium is a positively charged ion and chloride is a negatively charged ion. So I do have sodium and chloride which is more outside the cell. With the sodium, I am going to have the calcium also more outside the cell, and with the chloride, I am going to have bicarbonate which is also there more outside the cell. So please remember. If you cannot remember all of them, at least remember these four, that is the potassium, sodium, calcium and chloride. These four are the main you can say ions. You have to remember them. We just now talked about the equilibrium potential, that as soon as the concentration gradient and the electrical gradient, they are equal but opposite in the direction, as soon as that is going to happen, the force become equal as a tug of war, then the movement of that particular ion is going to stop, and whatever magnitude of potential we got during the rest, that is known as the equilibrium potential for that particular ion. So please remember, when we talk in terms of equilibrium potential or Nernst potential, we are going to talk for the in terms of the single ion, right? And the net flux is going to be zero whenever what will happen, whenever the net flux is zero, that means the movement is going to be stopped. The overall flow is going to be stopped. Now, what is the formula for Nernst equation? How do you calculate the equilibrium potential? I'm just writing in the short. Equilibrium potential can be calculated by the Nernst equation, that is RT by ZF, natural log of concentration outside upon concentration inside. But please remember, what is this R? What is this T? The R is the gas constant. T is the temperature, which again we are going to keep it constant. F is the Faraday's constant. So all of these things, Faraday's constant, all of these things are constant, and the Z is the valency, that depends on which type of ion you are measuring the equilibrium potential for, and what is their charge. That means whether it is positive, negative, what is it? Alright, and the CO and CI means concentration outside upon concentration inside. But please remember, calculating log, natural log, is a bit difficult. So what we are going to do, we are going to shift that formula into more easier version. And what is it? The equilibrium potential. If you calculate all the constants, the value will come out to be near about 61, and upon valency, depending on that ion, and then we are going to change it to log 10 of concentration outside upon concentration inside the cell. Alright, this is the easier formula, and it is very easy to calculate the log 10. Whatever number of zeros you are having, you're just going to put the number like that. Let's say log 10 of 10 is going to be 1. Log 10 of 100 is going to be 2, right? Like that. Now, moving on to the RMP, please remember, the equilibrium potential is different. Equilibrium potential is for the single ion. Unless and until its flux becomes zero, I'm going to calculate that. But when I'm going to talk about the RMP, it's not the single ion. Multiple ions are going to be involved there. So I cannot just stay on the basis of equilibrium potential. I cannot say that what is the RMP. Please remember, for the RMP, I'm going to have the another equation, which is known as Goldman-Hodgkin-Katz equation. Goldman-Hodgkin-Katz equation. Via that, I'm going to measure this RMP. Now, please remember, with the equilibrium potential, we require the P factor. What is P factor? That is permeability. I also want to know what is the permeability of that particular ion in that particular scenario for that cell membrane. Alright. So with the help of the multiplication of the equilibrium potential and the permeability, and we are going to add all that equilibrium potential and the multiplication of permeability, that is whatever factor comes for that particular ion, we are going to sum it for the different ions. And when the multiple ions we have calculated the GHK, we are going to say that this is going to be the RMP. Just remember the name GHK, that is Goldman-Hodgkin-Katz equation. You have to remember the numbers over here. What are the numbers? Equilibrium potential is different, that is for single ion, and the resting membrane potential is going to be for the cell. So please remember the sodium. Let's understand that. How we can understand it is that, let's say the sodium is more outside the cell, calcium is also more outside the cell. When I'm going to open a particular channel for them, what will happen? The sodium and calcium will move inside the cell, and as soon as they're positively charged ion, when they are going to move inside the cell, what will happen? They will also make the cell positive. They are going to bring that positivity inside, and they are going to make the cell positive also, right? On the other hand, if I talk about the potassium, what will happen? Potassium is also positively charged ion, but please remember that it is going to be more inside the cell. And if I open the potassium channel, what will happen? It will start going out of the cell. The efflux of the potassium will start. And because of this efflux, what will happen? The positivity is leaving the cell. So what will happen to the cell membrane potential? It is going to be negative. Same is going to happen in case of chloride. Chloride is the negatively charged ion, but it is more outside the cell. When the chloride start to move inside the cell, it will bring that positive negative charge with it. And what it will do to the cell membrane potential, it will make it negative. So potassium efflux, chloride influx, both of them going to make the cell negative. On the other hand, sodium or calcium influx, they are going to make the cell positive. So that's why we are going to write positive sign in front of the sodium and calcium. On the other hand, if you look at the chloride and potassium, it is going to be negative both the side. So plus 60 MV, that is going to be for the sodium. That is the equilibrium potential of the sodium. Sodium and chloride, they are close by. So please remember 60. After that comes the 70. Just remember there's a difference in the sign. Alright. So minus 70 is going to be for the chloride. Add 20 into it. That will become the potassium ka EP. That is nothing but the minus 90. Add 20 into it. That will become plus 110. That is going to be for the calcium. Calcium has the range of 100 to 130 millivolt. Alright, let's move on to the RMP. RMP is for the particular cell. So please remember RMP of neuron. You all know that this is going to be minus 70. In case of skeletal muscle and cardiac muscle, it is going to be minus 90 MV. In case of smooth muscle, it is going to be minus 50 MV. And SA node and the BER, that is the basal electrical rhythm, which is created by the GIT cells, especially the interstitial cells of Cajal, which is the pacemaker cell. So basal electrical rhythm. So that is going to be a fluctuating RMP, that is nothing but minus 40 to minus 60. Please remember this is RMP, this is not action potential, but it is going to be non-stable or unstable. Alright, so this is about the pacemaker cells. Now, if I ask you to focus on this thing that they all are in the negativity, that means the RMP, the normal polarity of the most of the cells are going to be negative, right? Why this is there? Because we have learned that during the rest, the potassium and chloride, they are going to move, and when their movement occurs, of course, it is going to make the cell negative, and that's why the normal polarity of cells are going to be negative. Let's move on to the IPSP and EPSP. What is IPSP and EPSP? Inhibitory post-synaptic potential or excitatory post-synaptic potential. When I'm talking about two neurons specifically, the communication between them is known as synapse, and whatever change is going to happen due to the first neurons or the presynaptic neuron, that is going to occur on the postsynaptic neuron. So whatever potential is going to be generated, that will be generated in the postsynaptic neuron, and that's why I'm going to call either inhibitory or excitatory postsynaptic potential, right? Who is going to generate the inhibitory postsynaptic potential? First is the potassium efflux or chloride influx. And in case of EPSP or excitatory postsynaptic potential, it is going to be sodium or calcium. Of course, influx, that means they are coming inside the cell. Alright, so please remember IPSP and EPSP. Let's move on with that. So RMP, who is going to generate the RMP? RMP is going to be generated mainly because of the potassium, because it is fully permeable during the rest, and then comes the chloride, which is partially permeable. If I ask you, does the sodium has any role in the RMP? Sodium alone has no role in the RMP. But if I ask you, does the Nokia pump, that is the sodium potassium ATPase, has any role? Yes, it is going to have minor role. Around 5 to 10% of the RMP is contributed by this sodium potassium pump. So please remember that. What is Nokia pump? Nokia means the sodium, N for sodium outside, potassium inside. ATPase, right? So Nokia means the sodium is going to thrown outside and potassium is going to be taken inside. ATPase means it is breaking down the ATP and taking all the energy from it to activate this Nokia pump or sodium potassium ATPase. Right? What is its coupling ratio? It's easy to remember. Sodium has 2 alphabet in its symbol. So add 1 into it, that becomes 3. And potassium has only 1 alphabet. Add 1 into it, that will become 2. So please remember the coupling ratio is going to be 3:2. That means it is going to throw out 3 sodium, 3 positively charged ion outside, and it is only going to take 2 potassium inside the cell. If I give you 3,000 rupees, in return you gave me 2,000 rupees back, so I'll be in the loss of 1,000 rupees. Same is going to happen with the cell. It will be in the loss of 1 positivity, or I can say that it is gaining 1 negativity. And we know that the normal polarity of the cells are going to be negative. So yes, it is going to contribute to the RMP. And why? Because it is active during the rest. Isn't it? Yes, it utilizes the energy, but it is active during the rest. So please remember, it is also known as electrogenic pump. Electrogenic pump, and it is going to maintain the high sodium concentration outside and high potassium concentration inside the cell. And that's why, because of this gradient, it is going to help me out in the RMP genesis. Now, please remember that during the rest, that means if you are not doing anything from last 1 hour, let's say you're sleeping, right, and thinking about the future, or you're not thinking even anything, still your sodium potassium pumps are going to be activated and maximum energy will be utilized by these pumps. They are present everywhere. So that's why we call these Nokia pumps are universal pump or omnipresent pump. And they are always active, even during the rest, even when you are sleeping. So I can say that whatever basic metabolism is happening even during the rest, that is happening because of them, because they are utilizing the energy. So please remember, the BMR is going to be dependent on the activity of the sodium potassium pump. Basal metabolic rate is going to be dependent on this pump. All right, let's move on and let's see how this pump looks like. If I zoom it out, this is going to look like this. Electron microscope, if I take under that, so that will give me the diagram like this, or schematic representation is shown over here. The alpha subunit and beta subunit, there are going to be 2 subunits. Beta is for beautifying. That means only glycosylation will happen on the beta, and that will activate the alpha. And all of the binding site, how many binding site do we have? We have 5 binding sites which are going to be present on the alpha. What are the sites and how to remember? The mnemonic is OK-NAP. How to remember? O for uabin binding site, K for potassium binding site, NAP is NAP, that is the sodium binding site, ATP binding site, and phosphorylation site. Please remember, all 5 out of these 5 are going to be on the alpha and alpha subunit only. Beta is just for the beautifying or activation. If beta is not there, will this pump work? No. For the activation of this pump, we require the beta. Now let's move on to the stimulators. What are the hormones which are going to stimulate these Nokia pumps, which are present on all the nucleated cell mainly? So please remember, the mnemonic is Tika over here. What is Tika? When you go somewhere, your mother or your parents, they are going to put the Tika. So remember, Tika is something that is going to stimulate. So T is for thyroid. Please remember, thyroid hormone is going to act on the genes directly, and it is going to increase the number of the sodium potassium ATPase directly on the cell. And if I talk about I is for insulin. Whenever you are going to give the insulin, this pump activity is going to be increased, not the number, but activity. C for catecholamine. Again, it is going to increase the activity of the pump. And aldosterone. Aldosterone can activate both the number also and the activity also. It can increase the number as well as activity. Please remember that. And if I talk about inhibitors, the digoxin, digitalis, where they bind to the uabin binding site, and they're going to block this pump, right? Then comes the diuretics. Then comes the atrial natriuretic peptides. All of them are going to inhibit this Nokia pump. Alright, so please remember that. And then comes the action potential. The site of generation will be asked, and it is going to be confusing in all other books. Why? Because the concept is very clear that if it is, there are two types of neurons, motor neuron and sensory neuron. If it is given as motor neuron, please remember it is going to be initial segment and initial segment only, where the action potential is going to be produced. Right? Now, how to remember this? The mnemonic is Miss Senorita. How to remember? Miss is what? Miss is motor initial segment, and Senorita is what? SE for sensory neurons, and Senor, NOR, that is nothing but the nodes of Ranvier. The gap between the myelin sheet, that is known as the nodes of Ranvier. So please remember Miss Senorita, alright, or Miss Senor. If they have asked about the motor, you can say neuron, then the action potential will be generated at initial segment. If they talk about sensory, it is going to be nodes of Ranvier. If I quickly draw the action potential in the nerve, how it is going to look like? What is the RMP? RMP is minus 70. Now, please remember, whenever I'm going to give the threshold stimulus, that means the minimum amount of stimulus which is going to produce the response, then how much it will be? What is the minimum stimulus that I have to give? That is nothing but the plus 15 MV, that is plus 15 millivolt. Now, if I give plus 15 millivolt ka stimulus, what will happen? The potential is going to go towards the less negativity, that is going to be minus 55 millivolt. Right? Minus 55 millivolt is more positive as compared to minus 70 millivolt. And there the firing of action potential will start, and that's why it is known as firing level. What happens once the potential reaches to this firing level? There are going to be channels which are going to open, that is sodium channels are going to open up. And when the sodium channel opens up, they will call more and more sodiums via opening more and more channel, that is known as Hodgkin's cycle. And when you are going away from the normal negative polarity, this is known as depolarization. When you are going to go towards the positivity, it is called as depolarization. And when you are going to come back, that is known as, when you are returning back, that is known as repolarization. And till what point the depolarization is going to occur? Till infinity kya? No, only till the point where you are going to reach to the peak, that is known as spike potential. Peak of it is known as spike potential. At the spike potential, no matter which you can say the tissue they have asked about, whether it is nodal tissue, whether it is cardiac muscle, please remember two things you have to do. Whatever channel is open, close that channel. So which channel was open? Sodium channel was open. So close that channel. So sodium channel closes, and which channel is going to open? Always open potassium channel. So potassium channel is going to be open. And when the potassium channel is open, we know that the potassium is going to move outside the cell. So that will cause the potassium movement outside the cell, that is potassium efflux. The potassium efflux is going to cause the repolarization. Now understand, the potassium channels are Kachua channels. That means they are very slow. When they reach to the RMP, they should close immediately, but that doesn't happen. They will take some time to close the ion channels. While they were closing, some more and more potassium will go outside the cell, and hence we are going to have the terminology which is known as hyperpolarization phenomena, which is also seen in the nerve, right? Now, why this is there? Because of the slow closure of potassium channel. All right. So this is all about the action potential of the nerve. Please remember, if someone asks you what is the reason for the hyperpolarization in the nerve, that is going to be the slow closure of potassium channel. Right? With that, let's move on and let's see what is the question that is given over here. There will be 3 graphs which are going to be shown. 2 things you have to do. First of all, don't get scared. And the second thing is, look at the X and Y axis. Now, on the X axis, we do have time. So there is no much of the use of it. But if you look at the Y axis, what we are having over here, we are having the relative permeability and we are having the membrane potential. Now understand, the action potential graph is already given to you. already given to you, and look over here, the firing level is already given. We have to identify. Of course, they are going to give X and Y over here. They will not give you the pK or PNA. That means the permeability of that particular ion, right? You have to identify which ion it is there. Now, how to identify it and what is the mnemonic for this? Now, please remember the sodium influx. When the sodium channels are going to open, the sodium influx will occur. So, there is a mnemonic which is known as Dinkar. What is Dinkar? The depolarization is because of influx of sodium, and the potassium efflux causes repolarization. So please remember, during the depolarization, the sodium channels are going to open, and no matter which you can say tissue is given, repolarization is always and always going to be because of the potassium channel. So please remember, X over here is sodium. Why I'm saying so? If you follow the path, you see that at threshold level, this brown color permeability or brown color ion permeability is increasing as per the action potential. And as soon as we reach to the spike, what we do? We close the sodium channel, right? So sodium permeability is of course going to decrease, and that's why it is the sodium ion channel. And if I look at the potassium ion channels, what will happen over here? That the potassium is going to increase when we are going to open up the channel. Almost when we are going to open up the channel, then its permeability will increase, and it is going to decrease slowly and steadily, right? So please remember, the first comes the sodium and then comes the potassium. Please remember that. It's an easy question. Coming to the refractility, refractility literally means no response, no second response. So there will be no second response which is possible in this case. Why? Because the sodium channels are actually getting inactivated. It requires some energy to activate back them. Alright. Now, from where to where? From starting, or I can say from the firing level. You can write as start or from the firing level. From the firing level till the 1/3 of repolarization is complete. What I mean by 1/3 of repolarization is complete? Look over here, that if I make the 3 parts of this repolarization phase, that will become something like this: first part, second part, and third part. Now, from here to here, especially from the firing level to this level, what is it? That is nothing but the absolute refractory period, and till the point from where the 1/3 as repolarization has been completed, and till the point it comes back to the normal condition, that is normal RMP, that period is known as relative refractory period, RRP. Absolute refractory period and relative refractory period. So if I talk about the starting or the firing level till the 1/3 of repolarization, we all know that is none other than the absolute refractory period. And from 1/3 of repolarization to the point where it is going to the polarization or the potential come back to the RMP, that is known as RRP, relative refractory period. Now, please understand, in the absolute refractory means absolute no response. No matter how strong stimulus you give, it is not going to give you any response. On the other hand, in the relative refractory period, what happens is, if you give a stronger stimulus, it will provoke the second action potential without causing the complete repolarization. Alright, so that is known as relative refractory period. Now, what is the significance of this? Please remember that the ARP is going to be much higher, or it is prolonged in the, you can say, in the heart muscle. So, long ARP. That's why the heart muscle cannot go in the sustained contraction, and that's why the cardiac arrest will not occur due to this long ARP. Thanks to this long ARP, the heart muscle cannot be tetanized. On the other hand, if I talk about the RRP, that is relative refractory period, definitely what will happen, that if you give the abnormal stimulus in the RRP, and if it is stronger than the normal threshold stimulus, definitely it is going to produce the second response, but it should be stronger. The stimulus should be stronger than the first stimulus. Now understand, ectopics means something abnormal. If the abnormal foci fires and then you see the abnormal contraction before even the complete relaxation happened, that is known as premature. ventricular contraction, premature ventricular contraction that is going to take place over here. And what is the most risky period for arrhythmia? Most risky period for arrhythmia is going to be ARR, that is the RRP. So please remember, most risky period for arrhythmia is going to be your RRP. So please remember that it is going to be again RRP, risky period for arrhythmia. Alright, why we know that? Because it can produce the second action potential. If I ask you this question, pause the video, solve the question and come back. True statement regarding the given nerve action potential. Threshold is at A point. Is it that threshold? No, this is not the threshold. This is the RMP which is shown. This is the threshold, that is B point. At E point, the nerve is more excitable. See over here, the E point is here. I cannot say that this is going to be the most excitable phase. It is going to take a lot of time and a lot of effort to stimulate the nerve again and bring that negativity towards the firing level, at least so that the action potential can fire up. So please remember, it cannot be more excitable. It is the least excitable phase of the nerve's action potential. So this is not true. This is also not true. Point C to D is due to the opening of sodium and closure of potassium. No, it is the vice versa. It is the closure of sodium and opening of potassium ion channel. What about point D? Point B to D is the refractory period. That's true. Point B to D is going to be the absolute refractory period. They have not mentioned which of the refractory period. We are assuming that it must be the absolute refractory period. Moving on to the Sedan's classification. Sedan's classification is dependent on the nerve and its structure, as we have more tensile strength into the covering and not into the axon. So whenever I'm going to give mild or moderate trauma, what is going to happen? Definitely the axon in between is going to get damaged, not the covering. Please remember that. Why that happens? Because the covering has more tensile strength. Alright, so this is the normal scenario. The nerve or the axon is covered by the endoneurium first, then comes the perineurium, and then comes the epineurium. So from outer to inner, epineurium, myelin sheath, that is nothing but the epineurium, endoneurium. Endoneurium is the innermost part, and in between I'm going to have the perineurium, which is not shown in this diagram. Anyways, if you have the questions such as given as honeymoon palsy, crutch palsy, Saturday night palsy, in that what happens is the patient is going to drink or the patient is going to lie down, on which the arm is going to get compressed because of this crutch palsy, honeymoon palsy or Saturday night palsy. Now, if it is compressed, what will happen? That in between whatever axon is there, that part will be damaged. Why? Because it is not getting a proper oxygen or carbon dioxide, right? So what will happen? You don't have to do anything. Just ask the husband or ask the, you can say partner, or ask the patient to just leave it like that or relax the arm. Why? Because it is going to heal on its own, right? That is known as neuropraxia in this case. Neuropraxia in this case, it is just the mechanical energy due to compression. It is not the physical per se damage. All right. So neuropraxia means pressure energy, which is going to destroy the covering. All right. Next is the axontomasis. I told you that the coverings are going to have the more tensile strength. On the other hand, axon is going to be very fragile in that scenario. So as soon as the injury will be a little bit more severe as compared to the neuropraxia, what will happen? Who is going to break down first? Of course, the axon is going to break down first. And you can see over here, the axon has broken down into multiple pieces. So please remember, the next thing that is going to come into mind is axontomasis. They have asked the question that the nerve sheath is intact, that means covering is intact, but the axon is damaged. Then it is going to be the axontomasis. What if the axon covering is also damaged and the axon itself is also damaged? That means there are two different parts or more than two parts are there of that particular neuron. Then this will be called as the neurotomasis. Why it is known as neurotomasis? Because not only just the covering but also the axon is damaged. There are two separate parts of this axon. So this is the most severe injury to the nerve which is possible. So please remember that the question has already come on these two. If the sheath is intact, axontemesis. Sheath is also gone and the axon is also gone, it is going to be called as the neurotemesis. Neurotemesis, and that is going to come under the Sedan's classification. Coming to the myelin, you all know that in the CNS, the myelination is going to occur because of the oligodendrocyte, and in the peripheral nervous system, it is going to happen because of the Schwann cell. All right. So this is none other than the diagrammatical representation, and what these myelin sheaths are going to do, they are going to wrap the axon surrounding them. Right, when they are going to wrap around, what will happen? The nodes of Ranvier will also be developed where they are not wrapping, that is the gaps between them. Now look over here, the Schwann cells are going to wrap around only one side of that particular neuron, but that is not in the case of oligodendrocyte. Oligodendrocyte not only covering multiple sites on one neuron, but they are covering the other neurons also. So if the antibodies are formed against these oligodendrocytes, which is going to be much severe, and that is none other than your multiple sclerosis. Multiple sclerosis, that is the disease that is going to take place, which is going to be much more severe. So please remember, when the antibodies are formed against the CNS myelin sheath, that is going to be called as multiple sclerosis. Alright, with that, let's move on towards the exoplasmic flow. If I have to transfer something such as a nerve growth factor, mitochondria, vesicles, neurotransmitter from the soma of the neuron till the axon terminal of the neuron, what should I do? I should have the tract. First of all, we have talked about the tract in the general physiology. It is made up of tubulin protein, and microtubules are going to form this tract. But I require those railway cargoes also, the dabbas also, the cargoes which are going to carry the neurotransmitter or whatever substance you want to transfer. So those cargoes are going to go in both the direction. First of all, they are going to go from the soma towards the axon terminal. If the direction is from the soma towards the axon terminal, this is known as anterograde transport. Anterograde transport. And if the direction is reverse, that is known as the retrograde transport. If the arrows are already shown, so see over here, retrograde transport. Now please remember, the anterograde and retrograde, they are going to have different cargoes which are going to carry the particular substances. What are those different things are called as? The first thing which is known as, or the first anterograde transport, that is known as kinesin. And some part of or some types of myosin also help us out to have that anterograde transport. On the other hand, if I talk about the retrograde transport, who is going to help me out? There is a protein which is known as dynin. Please remember, it is not dynamin, it is the dynin which is going to help us out. Now, why we require retrograde transport? Because whatever is leftover part of the neurotransmitter, vesicle, nerve growth factor, mitochondria, they need to come back to get refilled or recycled into the soma. So that's why they are going to come back. But there is a problem. What is the problem? There are some toxins or viruses such as rabies, herpes, polio, tetanus. So what is in their case? That they are going to attach to that cargo and they are going to come back. Right? Once they have reached to the soma, what will happen? The person will die because we cannot treat these patients, right? So please remember, the dynin helps to die. That means rabies, tetanus, herpes, polio. They are going to give you the scenario and they are going to ask you which of the following protein is going to help us out. That is none other than retrograde transport. Please remember, the person is going to die, and that's why remember the name dynin. All right. Let's move on to the Erlanger and Gasser classification. These Erlanger and Gasser, they were the scientists. They say that there are going to be 3 types of nerve fibers. What are the 3 types? A, B, and C. A, B, and C fibers. A are the largest fibers, B are the smaller as compared to A, and C are the smallest one. Out of that, A is the thick myelinated fiber, B is thin myelinated fiber, and C is thin, but it is unmyelinated fiber. Thin unmyelinated fiber. So please remember, as you go from A to B to C, the diameter is going to decrease, the myelination is also going to decrease. Hence, what will happen to the overall velocities? The velocity, overall velocity is also going to, velocity means the speed of conduction is also going to decrease. Alright, so please remember that. Now, if I say that A is going to have 4 different subtypes also. So, what are the subtypes? Alpha, beta, gamma, delta. First of all, let's cover up B and C, which is easiest one. B has only one work. You must have heard about preganglionic fibers, postganglionic fibers, that the parasympathetic has longer preganglionic but shorter postganglionic fibers, right? And vice versa in the sympathetic, that the preganglionic are shorter and the postganglionic are longer. Now, please remember, what are those preganglionic and ganglionic fibers? They are none other than these B fiber and C fiber. So we do have two systems, that is the sympathetic and parasympathetic system, that comes under this ANS, autonomic nervous system. So please remember, the preganglionic autonomic nervous system fibers, they are going to be B fibers, and postganglionic ANS fiber, they are going to be C fibers. C fiber also carries some sensation, that is nothing but the pain and temperature. Pain and temperature is carried by the C fiber. But there is a twist. What is the twist? That not only the C fiber but also the A delta fibers can carry the pain and temperature. So pain and temperature is also carried by the A delta fiber, and just now we saw that A delta fibers are going to be faster as compared to the C. So please remember, if I have to divide the pain into fast and slow, then I can say that the fast pain and temperature is carried by A delta fiber, and C fibers are going to carry the slow pain and temperature. Now, how to remember this? First of all, just remember about the C fiber. Then come to the A fiber. A has 4 different subtypes, that is alpha, beta, gamma, delta. Now, out of that, 2 are going to be motor, 2 are going to be sensory. Now, please remember which are the motor ones. First of all, the alpha motor neuron you must have heard about, gamma motor neuron you must have heard about, right? So, please remember, the alpha motor neuron and the gamma motor neuron, they are going to be called as the motor neurons. But again, medicine is not that easy. There are going to be some exception. What is the exception over here? That alpha is not only just motor, but please remember that it is going to carry the sensation of position, that is proprioception. It is also going to carry the sensation of position. That means where your hand will be, exactly you will know without even looking at it. If I ask you to close your eyes, you will be able to tell me that there is my hand. How this is possible? Thanks to these A alpha fibers, right? Now, I told you that A gamma is also motor. It doesn't have, thankfully, it doesn't carry any sensation or motor pathway. Now, see over here, A gamma fibers are, I told you that A gamma fibers are also the motor fibers. Thankfully, it doesn't carry any sensation, right? So, A alpha and gamma are motor. With that, A alpha is going to carry the sensation of proprioception. On the other hand, if I talk about beta, beta is going to carry rest all sensation. What I mean by that? Rest all sensation means if they ask about touch, if they ask about pressure, if they ask about, let's say, 2-point discrimination, vibration, stereognosis, all these sensations. Two-point discrimination. All these, you can say, sensations, they will be carried by A beta. Alright, so how to remember? Alpha, beta, gamma, delta. Alpha and gamma, they are motor. With that, the alpha carries the proprioception, and we know that the A delta and the C fibers, they are going to carry the pain and temperature. So rest all the sensation except pain, temperature and proprioception. All other sensations will be carried by A beta and A beta only. Now, we have already drawn this diagram, so it is going to be very, very easy for us. If I say that if I start compressing these areas or spaces. So what do you think, which is going to affect first? Of course, whichever is larger, that is going to get affected first. That is nothing but, if I give the pressure, the A fiber will be more susceptible as compared to B, as compared to the C. So A fiber will be more affected than B, then C. If I talk about hypoxia, if someone went on the mountain, right, and he called you that I'm feeling dyspneic or I'm feeling hypoxia, what is your first advice? To come back on the sea level, right? So remember, that is the mnemonic for us, that is to come back. That is, B is most susceptible as compared to A and as compared to C. So please remember, this is shown over here that the pressure, when I'm going to talk about, it is A more than B more than C, and hypoxia is B more than A more than C. All right. So please remember that. Now coming to the strength duration curve, it's the easiest curve. Please remember, only two things you have to remember, that is what is Rio base and what is the chronexy. Rio base is amount of strength that you're giving. That means when I give the minimum amount of strength of stimulus, when I'm going to give that whenever I require the response. So the minimum amount of stimulus given for the adequate time, it is going to show the response. So that minimum amount of stimulus or minimum strength of stimulus is known as the Rio base. So see over here, Rio base is shown. So this is the Rio base. When I have given it for the adequate time, it will show me the response. When I talk about, if this was the Rio base, I gave double that of the Rio base, what will happen now? Less time is required to give the response. So I'm going to measure that time. All right. So the Rio base and chronexy, when I'm going to measure that duration, that will be called as the chronexy. So I can say, whenever I'm going to give the double that of the Rio base stimulus, in what time I got this response, that will be called as the chronexy. So please remember, the minimum intensity of current required to stimulate a muscle or the muscle to respond, that is known as the Rio base, when it should be given for the adequate time. And what about chronexy? The time required. Please remember, chronexy is the time and the Rio base is the strength of stimulus. So time required for the current to give the response when we have given double that of the Rio base, that means 2x of the Rio base stimulus. At that time, how much time was required? Now it is having a clinical correlationship. Please remember, it is inversely proportional to the excitability. That means if you have lesser chronexy, the cell is more excitable. If you have more chronexy, the cell is lesser excitable. All right, and it is going to be very prolonged in case of the nerve damage, that is denervated muscle especially. All right, so please remember that. So now let's discuss about EC coupling. What is EC coupling? Excitation contraction coupling. We have to excite the muscle via the action potential of the nerve, and then we have to contract it. Let's see how this is going to happen. First of all, what I want is 200% concentration of you guys. See over here, first of all, I'll give you the overview. This is the muscle and this is the nerve which is stimulating that muscle. And the junction between these two, we are going to call it as NMJ, that is neuromuscular junction. At neuromuscular junction, we know that the neurotransmitter is going to be acetylcholine. And see over here, we have already seen, as soon as what happens, as soon as the action potential travels along the nerve, what is going to happen at the axon terminal? There will be ion channel. Which ion channel? There will be calcium ion channel which will be open, and the calcium is going to come inside. As soon as the calcium comes inside, it is going to do two things. Calcium in the nerve muscle physiology or overall in body, what it does, it is required for two things. First thing, if it is getting inside the muscle, it is going to cause contraction. If it is not the muscle, it is going to cause exocytosis. It is not the muscle, it is the nerve. So it is going to cause the exocytosis of the neurotransmitter. Which neurotransmitter? Acetylcholine. So that is the role of the nerve in the excitation contraction coupling. So yes, the action potential happened, and finally, with the help of calcium, the acetylcholine got released from the nerve. Now, what will happen to this acetylcholine? This acetylcholine will go and attach to the acetylcholine receptor. Now, understand, usually these receptors are very close to each other like this. Okay, as soon as the acetylcholine is going to sit onto these two receptors or their seats, what is going to happen? These receptors themselves, they act as a channel and they are going to give the space in between. That means they are going to open up. And what are these channels? These channels are non-selective cation channels. That means they are not particularly selective about any specific cation. But remember that the influx rate of the sodium is much higher, and that's why these channels will be also known as the ligand gated. Why we have called them as ligand gated? Please remember, we have called them as ligand gated because they are opened because of the ligand. What was the ligand? Acetylcholine is the ligand over here. Ligand gated sodium channel because the sodium flow or the sodium influx is going to be much higher as compared to any other cation via this channel. So we will say that this is the sodium channels. Alright, what will happen? Because of the sodium entry, that is nothing but the positively charged ion, a lot of positivity is going to build up inside the cell and the action potential will be generated if the sufficient amount of acetylcholine has been released. And because of that, action potential will be produced, and this action potential is now produced in the muscle. Now the muscle is not going to be a straight line, or its membrane is not going to be a straight line. It is going to have tubules, two types of tubules. So see over here, if this is the muscle membrane, we are going to call it as sarco, especially in case of skeletal muscle. Sarcolemma, that means the membrane of skeletal muscle. It is going to have two tubules. What are the two tubules? First, if the tubule is present in transverse to the membrane of the muscle, we are going to call it as T-tubule or transverse tubule. If the tubule is longitudinal to the muscle membrane, we are going to call it as L-tubule. So there are two tubules, T-tubule and L-tubule. What is L-tubule? L-tubule is nothing but the membrane of the sarcoplasmic reticulum inside that muscle. Now, the T-tubule is going to have, as well as the L-tubule, going to have channels, calcium channels. Again, we are talking about the muscles. There are two channels. What are those two channels? On T-tubule, please remember this is the PYQ. Pay the attention over here. On the T-tubule, we are going to have DHPR channel. What is DHPR? Dihydropyridine receptor. Again, I am telling dihydropyridine receptor. What is going to happen? As soon as the action potential is going to follow this T-tubule, because it's a property of action potential to propagate. Now, it is going to activate the DHPR. Again, I'm saying it is going to activate, not open. In the skeletal muscle, it just activates the DHPR channel. As soon as the DHPR got activated, it is connected with the mechanical connection to another calcium channel present on the L-tubule. What is that channel? That channel is nothing but ryanodine receptor or ryanodine channel. Now, as soon as what is going to happen, this DHPR got stimulated. See over here, this is the condition in the resting case. As soon as they are stimulated, what will happen? The spring-like structure will coil, and because of that, the RYR is going to open up. As soon as this RYR is opened up, what is going to happen? Of course, this sarcoplasmic reticulum has lots and lots of calcium. That calcium is going to rush inside the myoplasm. That means inside the muscle it is going to come, and we all know, just now we discussed that the calcium is going to do two things. If it is a muscle, it is going to cause contraction. And right now we are talking about the muscle. So yes, as soon as the calcium comes, what is going to happen? Definitely the calcium will rush into the myoplasm, and that is going to cause the contraction. That is nothing but the actin myosin cross bridge formation and their power stroke. Alright, so that is how it is going to work. 2-3 questions will come. T-tubule pe which channel is present? DHPR. On the L-tubule, which channel is present? The RYR. And they are connected with the mechanical coupling. They are not connected with any other coupling. And there is no role of ECF calcium into the contraction of the skeletal muscle. Why? Because DHPR is just getting activated. It is not going to open in the skeletal muscle. It is a little bit different in the cardiac muscle and the smooth muscle. Yes, in rest of the two, that means except the skeletal muscle, in the cardiac muscle and the smooth muscle, we do have some role of the ECF calcium, but not at all in the skeletal muscle. The skeletal muscle calcium source is only and only sarcoplasmic calcium. right? Sarcoplasmic reticulum, calcium. Now, if we have talked about the contraction, now I want to relax the muscle. Now, what we need to do? We need to send that calcium back into the sarcoplasmic reticulum. How we are going to send it back? We have one channel, or we can say we have one pump. Of course, we are going to go against the concentration gradient. So, we require the energy utilization. And what is that pump? That pump is calcium ATPase. But since this is present in the muscle, we are going to call it as Sarca pump. What is Sarca pump? The CA is for calcium ATPase. But what is this Sarca? Sarcoendoplasmic reticulum calcium ATPase. That is the full name. Nobody will ask you. This is also known as Sarca. This is nothing but the primary active transport, because we are going to go from the low concentration to high concentration against the concentration gradient. We require the energy. As soon as the calcium is going to go back into the sarcoplasmic reticulum, the muscle will relax. So that is the excitation contraction coupling. Again, in overview, what we have done, action potential ko we have converted into mechanical energy, that is contraction. Mechanical things you can see by the eyes, the electrical things we cannot see. All right, so excitation is the electrical phenomena, contraction is mechanical phenomena. All right, let's move on. If we have learned about the RYR, if there is a gain of mutation, that means it became hypersensitive. What is going to happen? If the RYR became hypersensitive, the person will release lots and lots of calcium, and unnecessary excessive contraction will occur. And whenever the muscle contraction occurs, two things are always going to take place. First of all, there will be utilization of energy, that is ATP. And the second thing is that there will be production of heat. Now, this is unnecessarily excessively high calcium which got released from the sarcoplasmic reticulum just because of the gain of mutation of RYR. What will happen to the heat generation? Of course, there is excessive high or exaggerated contraction of the muscle, and excessive heat production will occur. And that condition is known as malignant hypothermia. Malignant hypothermia. So, please note that down. Alright, now we have learned that calcium came into the myoplasm and then the contraction happens. What actually is happening on the molecular basis? Let's see. Now, before going to go towards that, just see this diagram and the meme. Wonderful meme you can remember. There is a actin and myosin. Of course, we are going to, do the connection between these two whenever we want to contract the muscle. But there is someone who is inhibiting it, and who is that? That is nothing but Papaji of myosin. That means daddy of myosin, that is tropomyosin. Tropomyosin is not allowing the actin to meet with the myosin. Now, if we want to do the contraction, what we need to do? We need to distract the Papaji, right? How to distract the Papaji? So, we do have calcium, and calcium is going to go and bind to the protein which is known as troponin. Troponin is the heterotrimeric protein which is going to have three different molecules. So, troponin T, troponin I and troponin C. Please remember, the calcium is going to go and attach to the troponin C. C for calcium. So, this calcium will go and bind to the troponin C, and it will, these two are going to form the troponin calcium complex. As soon as this troponin calcium complex is formed, now they are able to distract the tropomyosin, or we can say displace the tropomyosin. So, in this diagram, you can see that there is the blue color round bodies. These are nothing but the actin molecules which are again forming the filamentous structure. And what is this dark blue color? That is nothing but the active site of actin where the myosin head can bind. But the problem is that is covered with the tropomyosin. So, what the tropomyosin do in the resting condition where the muscle is relaxing? At that time, the tropomyosin covers the active site of actin and do not allow the myosin to bind to it. As soon as the calcium troponin complex is going to form, what will happen? Of course, the tropomyosin will be displaced away from the active site of actin. Now, these active site of actin are free to bind to the myosin, and that's how the actin-myosin cross bridge is going to be formed. So, this is how the contraction takes place, right? So, please remember actin-myosin, then tropomyosin and troponin, right? Now, one more protein I want you to remember, that is titin. What is the titin? This is the largest molecule or largest protein available in human body, and please remember, it gives the elasticity to muscle. especially elasticity to skeletal muscle. Why I'm saying? Because in the smooth muscle, this is going to be absent. And that's why the smooth muscle, because of the absence of titin, it is going to be having the another property, that is plasticity. It is moldable, not like skeletal muscle. Alright, and that's why this titin is also known as muscle spring. I'll just write it completely. That is muscle spring, right, which is absent in the smooth muscle, and because of the absence of titin, the smooth muscle is going to have the property that is known as the plasticity or adaptability. All right, so please remember that. Now, what is the applied aspect of it? Either the antibodies can be formed against this calcium channels, which are voltage gated calcium channels present in the nerve, or the antibodies can be formed against the acetylcholine receptor. If it is not there in the option, we can write it as musk protein also. If the antibodies are there presynaptically, or we can say in the nerve, then it is called as Lambert-Eaton syndrome. Lambert-Eaton syndrome. And please remember, if the antibodies are formed against the acetylcholine receptor, it is known as myasthenia gravis. Now, how to remember? Of course, you will again discuss that in the medicine. But remember, E and M, Eaton, may there is E present, and myasthenia may M is present. So please remember, please remember that the Lambert-Eaton patient is going to be better in the evening. He'll have the problem in the muscle contraction during the earlier time of the day, or whenever the muscle got stimulated, right? As soon as he starts stimulating muscle more and more, the calcium will overcome the antibody concentration outside the channel. And now you can see this is a very nice representation, very cute representation, that the calcium is able to open the gate finally when its concentration is going to be higher because of the multiple stimulation. Opposite, exact opposite is going to happen in the myasthenia gravis. The patient is going to be better in the morning because he has the lots and lots of acetylcholine in the morning. But as soon as he started to utilize it, definitely the concentration of acetylcholine is reduced and it takes more time to produce it again. So that's why the patient is better in the morning, and the patient will develop ptosis, muscle weakness, all these symptoms in the evening. So remember the Lambert-Eaton and myasthenia gravis. Now let's see the molecular mechanism or molecular bands and the lines in the muscle. So imagine that this pink one is the myosin, the complete myosin. Whether it is non-overlapped by the actin or it is overlapped by the actin doesn't matter. The whole of the myosin is known as A band. So it is known as A band. And these green molecules, they are the actin molecules. Alright. Now, please remember, only actin, that means we are going to take the actin which is non-overlapped by the myosin. Only actin is known as I band. If I draw a middle line, imaginary middle line, or it is actually made up by the proteins. So, if I draw the midline of the, I take the midline of the I band, that will be called as Z line. So there will be Z line on one side of the myosin, there will be Z line on the another side of the myosin. Okay, please mention it that it is the midline of the I band, not the midline of the actin. I band is different, actin is different. Non-overlap actin is known as I band. Alright, and from one Z line to consecutive Z line, we are going to call it as sarcomere, which is the functional and structural unit of the muscle. Alright, and exactly in the middle of sarcomere, we are going to have something known as M line. So remember M as middle. Remember that. It is not actually for the middle, but we can remember, right, to make our life easier. Now, as we discussed that the only actin is known as the I band. So there must be something which is also there to, denote that there is only myosin. That is nothing but your H zone. H zone is only myosin. So what happens during contraction? It is the symmetrical action that is going to happen by the myosin head. As soon as the calcium is going to come, the myosin head will attach to the actin and they will bring the actin inward. And because of that, what is going to happen? See, in the contraction, because of that, the Z lines start to come closer. The I band will reduce, and of course, if the I band reduces, the distance between Z line also decreases. So I band decreases, Z line decreases. What will happen to the H zone? H zone also, you can see that H zone will also decrease, and this is the only thing which can disappear after complete contraction. So it can disappear also. So please remember, if there is a complete overlap of the actin and myosin, definitely this H zone is going to disappear. And what about the A band and M line? See, M line is not going to change because it will stay in the middle, right? So M line will not change. And who else will not change? The A band is also not going to change. So please remember, Ma never changes. That means even if, no matter what age you are of, if Ma wants to scold you, she will scold you, right? So no matter what happens, Ma will never change. Remember, that is the mnemonic for this, you can say, sarcomere. All right. So this is the structure of the sarcomere. Ma will never change. That means M line and A band will never change. Rest all things are going to reduce, and H zone is also can disappear. All right, so let's move on. Now, they have asked in this question that from the periphery towards the center, we have to manage this. So please remember one mnemonic, that is Zaham. What is it? The Z line will come, then the A band, then the H zone, and then exactly in the middle, we are going to have the M line. So Zaham. So over here, Z line will come first, that is the first one. A band, that is third one. So 1, 3, and then 4 and 2. So option C is going to be the answer. Zaham, please remember. Next is dystrophin. It is the protein which is going to attach to the actin and to the sarcomere on the other hand, right? And it is able to keep the actin on its place so that when the next contraction is going to occur, it can occur very smoothly, and we can able to produce the force for the action, for the acting against the gravity, right? Now, if the dystrophin protein is either mutated or partially absent, of course, the child will not be able to generate the force against the gravity. So, when he want to change his position, he is going to take the support available nearby. If the support is not available, he is going to take the support of his own bones, right? And it looks as if the child is climbing on his own body via taking the support of his own bone, and that is known as Gower sign. Now please remember, Gower sign is seen in mainly in the Duchenne muscular dystrophy. Can be seen in both, but Duchenne muscular, because in the Duchenne muscular dystrophy, the dystrophin is completely absent. So of course, this is going to be much more severe. Because it is mutated or partially present, Duchenne mate is completely absent. Now, there is a length tension relationship, and they have typically going to ask you where the force of muscle contraction is maximum. It is going to be maximum at these places. Now, on what thing the force of contraction is actually dependent on? It is dependent on the number of actin-myosin cross bridges. So, see over here, if I stretch the muscle too much, what is going to happen? The overlap between the myosin head and the actin will reduce, right? So what is going to happen? If I stretch a muscle, the muscle length is going to increase, and because of that, the actin molecules, they are going to be pulled apart. Now what is going to happen? Definitely the actin myosin cross bridges will decrease. On the other hand, if I contracted it too much, what will happen? See over here, the actin will overlap onto each other. So the active site of actin will be covered by the another actin, not the myosin. So they are also going to reduce the number of cross bridges. So because of that, what is going to happen? Again, the force of contraction will reduce. So where the force of contraction is maximum, it is going to be between here to here. Please remember, this is known as the optimum length. What is optimum length? Optimum length is the phenomena, or it is the length of the muscle where